I'm sorry, my net crashed, so now I am on a alternate Wi-Fi. Can you hear me?
Yes, sir.
Gautam, can you hear me?
Yes, sir, very clearly.
Okay. Okay, so this is standard Zoom, right? Share screen and all that.
Yes, sir.
So can you quickly share screen so that we can see that your slides are working? Then we can start the program.
Can you see it?
Yes, perfectly.
Can you
Yes,
see
sir.
it?
Yes, sir.
Okay. So I'll stop sharing.
Sir, make it full screen and check that the slides are going forward.
Yeah.
Yeah, okay, please click
Yeah,
and
it's okay.
all right, perfect.
This is fine. Yeah.
We are live now.
We are live. Just give me a minute for the webmaster to put that. Just 1 minute.
So we'll mute
Once I
ourselves,
get a
right?
confirmation from the webmaster, we'll do.
अटनकर सर का वीडियो बराबर नहीं है क्या?
हो बॅकग्राऊंड का प्रॉब्लेम आहे.
फोरग्राउंडच नाही दिसत.
सर बॅकग्राऊंड ते काढून टाका, नाही तर
बॅकग्राऊंड काढून टाकतो.
हो काढून टाका.
आय विल जस्ट डू द बॅकग्राऊंड. या
Hello, link you got? Link I sent on WhatsApp.
Bipin, your light is wrong.
Quickly tell when it is embedded.
So light is on the back now. It is not showing.
Should I put the background because that background is causing?
Remove.
Yeah, remove it.
Because they cannot. We'll have to restart. They'll have to restart.
Instead, make a background of Sunny Leone.
Yeah.
Like it better.
Then nobody will hear you.
Only 10 people have it.
आपण बिपिन पाठची लाईट बंद कर.
पाठी नाही, पुढे लाईट आहे.
पाठीमागे आहे ना.
Hemant, Gautam here.
Yeah. You see.
Hemant, are you on? Patankar.
Not helping. Now I'll get rid of the background.
Great. Can you play your share screen and show us that your presentation is working?
So meeting can start.
Okay, just as soon as this guy checks. All right, it's already 9:02. I'm going to go ahead and start, right? Good morning, all the viewers of this webinar on the internet. We have members of the Bombay Orthopedic Society, the Indian Orthopedic Association, the Maharashtra Orthopedic Association, the Indian Hand Surgery Society, and Indian Plastic Surgery Society. Right? Have joined us on this webinar today, and I welcome all of you. Orthopedic Society runs this bi-monthly program, which is called as the Master Cares and Master Shares program, where we go into the in-depth understanding of a particular topic. The COVID has in a sense worked good for us. We used to have these meetings physically previously, and we used to have about 100-150 people attending the meeting. Currently, the Master Cares and Master Shares has a viewership of upward of 3,000 people. So a lot more people are benefiting and appreciating these programs. Today, we have come up with a very different topic. A problem which all orthopedic surgeons see commonly in daily practice. And yet, one is unsure often about which is the way to proceed further. A lot of orthopedic surgeons do not deal specifically in suturing nerve injuries, etc. But there are times when you are called upon in an emergency in a small setup to do it. You must know the principles, you must know the basics, and that is what we will start with. We have with us a very young, dynamic coordinator of the program, a person who is extremely sincere and in a very short time has earned a huge reputation for himself as a hand surgeon, Dr. Parag Lad from Thane in Mumbai. Along with him, we have got some fantastic national and domestic facility from Bombay faculty. Nationally, we have got Dr. Hari Venkatramani from the Ganga Hospital in Coimbatore. We've got Dr. Anil Bhatt from Mangalore. We've got Dr. Amit Vyas, who comes from Rajasthan. And of course, we've got Dr. Anil Bhatia, who is world famous for his work on brachial plexus injuries and other nerve injuries from Pune or Bombay. I'm not sure what to say. And of course, from Bombay, we've got Dr. Mukund Thatte. Mukund Thatte was my teacher when I did my rotation in plastic surgery when I was a resident. He was a phenomenal teacher, and even at that stage when he was a lecturer or a senior lecturer, he was immensely respected, and that respect and fame has only grown over the years. Along with him, we have a host of young Bombay Orthopedic Society hand surgeons, surgeons who are interested in nerve injuries, which include Amit Varade, Bipin Gangurde, Rohan Happu, Kiran Ladkat, and I'm sure Parag will give more of an introduction to them. Let me not forget very essentially my friend and my colleague we work in the same hospital, Dr. Hemant Patankar, who is also a very, very famous hand surgeon across the country. So welcome. I'm sure you are in for a treat. The program is going to start with a couple of basic lectures on nerve injuries, classification, what to do, what not to do. And then we will move on to case presentation and various individual nerve injuries in the upper extremity. Over to you, Parag. Thank you very much.
Thank you, Dr. Gautam sir, for such a kind words. And I welcome all the faculty for this Master Cares and Master Shares program. Today's program we have designed in such a way that senior faculty is going to discuss about how to evaluate and classify and investigate a nerve injury. Then we will see how these injuries are tackled and how and what to do and what not to do by orthopedic surgeons. And then we are going to discuss all four major important nerves of the upper limb, which we usually are scared when we are doing a bone fixation, like axillary nerve and median nerve, radial nerve, ulnar nerve, and digital nerves in the hand. We have designed the program in such a way that first a case of that particular nerve injury will be presented and how that has been managed, and there will be a discussion, and then the formal talk that where else these injuries can occur and how if they occur, how it can be prevented. To introduce, Dr. Mukund Thatte is a senior plastic surgeon and hand surgeon in Bombay Hospital and Wadia Children's Hospital. Dr. Anil Bhatia is known brachial plexus and peripheral nerve surgeon from Bombay and Pune. Dr. Hari Venkatramani is from Coimbatore Ganga Hospital. He is a senior plastic hand surgeon. Dr. Hemant Patankar is our known national and international faculty from Bombay as a hand surgeon. Dr. Anil Bhatt is the head of the department orthopedics at KMC Manipal with keen interest in brachial plexus, peripheral nerve and wrist injuries. Dr. Rohan Habbu is from Nanavati. He practices as a hand surgeon. Dr. Kiran Ladkat is a hand surgeon at Jaslo. Dr. Bipin Gangurde is a hand surgeon at Hiranandani and in Andheri area working as a hand surgeon, as well as in Wadia Children's Hospital. Dr. Amit Vyas works in Jaipur as Jaipur Fortis as a hand surgeon. Dr. Amit Varade has his own hospital, Sopan Hospital in Nasik, as a hand surgeon. and Dr. Leena Jain is a plastic surgeon at Lilavati Hospital. Without wasting time, I welcome all my senior colleagues and faculty for this webinar. And now I invite Dr. Anil Bhatia to give his first talk. Welcome, Dr. Anil Bhatia. Thank you, sir.
Thank you, Parag, for the kind introduction and the invitation to participate in this. Let me get my right. Don't know. For some reason it's not coming on.
Sir, share the screen.
All right. Is the slide coming on?
Yes,
Hello?
sir. Yes,
Yeah,
sir.
Right. Right. So I was asked to speak on the evaluation of nerve injuries and the basics of what we need to know in management of peripheral nerve injuries. Just a second. Now, the peripheral nerve acts as a conduit between the central nervous system and the peripheral target organ. It has the motor and sensory components. The prefrontal cortex gives the orders, and the anterior horn cells in the spinal cord transmit the signals along the axons which exist in the peripheral nerve. The dendrites of the sensory pathway carry the sensory signals back to the brain. That is basic. What we have forgotten about the structure of the peripheral nerve, I would like to revise here. The neuron located in the, we'll take the motor neuron as the example, lying in the anterior horn of the spinal cord. It outward signals, efferent signals, would pass along the axons. Each axon is wrapped around by a lipid sheath, which is laid down by Schwann cells, and there are intermittent constrictions along those Schwann this myelin sheath, which are known as the nodes of Ranvier, and therefore this is what is known as a saltatory conduction. Motor conduction is faster than sensory conduction ordinarily. Each axon is wrapped in endoneurium. Bundles of axons would form fascicles, and bundles of fascicles would form group fascicles, and group fascicles would be wrapped around by the epineurium. What we actually see surgically are groups of fascicles. We cannot see actual fascicles even in the operating microscope. So what we describe as a perineurium or a epiperineural repair is actually still an epineural repair. Now, nerve injuries can be of two sorts. Those which would have no structural damage, and I'll come to that in a minute. But when there is a structural damage, it can be because of a penetrating injury in a variety of ways, or external compression through the skin, or what is mostly my practice, closed traction, where because of a high velocity impact during a two-wheeler accident, and the position of the limb subjects certain nerves which are vulnerable to traction. So all of us are familiar with these three terms which describe nerve injuries, but there is a lot of abuse of this particular term, neurapraxia, all along among orthopedic surgeons. So I have taken it upon myself to try and clarify a few of these terms. When we are dealing with a nerve injury where there is a temporary shutdown of function, but very rapidly it returns, that can be termed as a neurapraxia. It was this terminology came from Seddon based on clinical observations. And when there is no structural damage, there is a predominantly motor deficit. And since there is no structural damage, there is no histological change in the nerve, and there is no electrical change in the nerve distal to the site of injury. So recovery would happen very soon, within hours or within a few days. Therefore, if you are going to see recovery after months, that is certainly not neurapraxia. Again, the recovery doesn't happen in the sequence of innervation. Sometimes the distal portions recover earlier than the more proximal portions along the nerve. So there is a temporary cessation of conduction, and recovery happens very soon. So the most common example is a Saturday night palsy. Somebody is sleeping in an awkward position, maybe after having been drunk, and wakes up with a wrist drop. And this guy came to me 3 days after the onset, and already there was a partial recovery in the wrist extensor. The EPL seemed to show a flicker, and very soon, within a week, he had recovered full function. That and that alone should be termed as a neurapraxia. When there is a structural damage, a few things happen to the nerve. Firstly, the portion of the axon distal to the site of injury undergoes complete destruction, and macrophages mop up all the debris, and Schwann cells lay down empty tubes waiting for the growing axons from the proximal side. The same degeneration happens proximally up to the first node of Ranvier, and that is known as the retrograde degeneration. Immediately, or within a few days, the anterior horn cells or the neurons go into a phase of hyperactivity, and therefore the Nissel's granules disappear, and that term gives a term of granulolysis. But actually, it's not a lytic activity. In fact, it's a synthetic activity, and that works to cause axonal sprouting, starting from the first node of Ranvier proximal to the site of injury, and the axons will grow distally towards the empty Schwann cell tubes which are lying waiting, and the growth will happen at the rate of an inch per month or a millimeter per day, starting from a month after the injury. Therefore, if there is the overall covering of the nerve remains intact, and there is a structural damage, there would be a spontaneous recovery, but at the rate of an inch per month. And since the distal portion will shrink in that much time, the recovery may be incomplete. Now, before we go on to actual descriptions of the axonotmesis, I would like to just lay the ground by describing what the common electrodiagnostic tests, the EMG and the nerve conduction studies. EMG signifies the integrity of the pathway between the brain and spinal cord and the peripheral target organ. Ordinarily, the report that you will read will show a normal insertional activity, that is when the needle is crossing the epimysium, and a burst of electrical activity happens, after which essentially the skeletal muscle has no spontaneous activity. When the person is asked to exert force in that particular muscle, then the brain gives a signal which goes along the peripheral nerve. The motor end plate gets activated, and an electrical activity gets generated, which will be recorded as the motor unit potential. And as sequentially more and more motor fibers get recruited, there is recruitment and interference, like so. So as I said, if there is in an axonotmesis, there would be a structural damage, and therefore there would be Valerian degeneration, and the recovery might be incomplete. So let us see an example. What exactly does an axonotmesis signify? There was this closed fracture shaft of the humerus being operated. There was a deficit noted before surgery, so I was called in during fixation. Before I came in, the fixation had already been done by the anterolateral approach, and I examined the nerve in the beyond the spiral groove where it looked intact. But since I had been called in to explore and the deficit was present before surgery, I chose to do the posterior approach as well and examine the full length of the nerve from the lower part of the teres major distally. And the integrity of the nerve was confirmed. But post-surgery, the deficit persisted, so an EMG was done at 3 weeks. Why is it done at 3 weeks? Because Valerian degeneration takes 3 weeks to install, and no changes would be seen in the EMG before that. So that showed a total denervation. That signified that there was a structural damage. But I had already seen the nerve, so I advised the patient to wait. At 4 months, the brachioradialis recovered. And the EMG showed signs of re-innervation of the brachioradialis. A month later, you could clearly see the contraction of the brachioradialis and of the wrist ECRL, ECRB. And subsequently, he had full spontaneous recovery. So that is axonotmesis. But if the nerve is completely severed or has been torn apart by closed traction, there would be complete deficit in the sensory and motor territory, and there would be no spontaneous recovery. Or automatically, there would be a neuroma on the proximal side and a glioma on the distal side. Now, when for an EMG, we are going to document the structural damage by looking for Valerian degeneration, and that takes 3 weeks to install. Therefore, one should not do an EMG very quickly. Before that, one can do nerve conduction studies. So I'll just explain what happens in a nerve conduction study. You stimulate distally and pick up the signal proximally along the course of the nerve, and that would be recorded as a sensory nerve action potential. If you stimulate proximally and pick it up distally, what you get is a motor unit compound motor action potential, or CMAP. So in a neuropraxia, as I said, there is no structural damage, and therefore there might be a slowing of conduction at the site of injury, but the distal portions would show normal conduction. Whereas if there is a structural damage, there would be a shutdown. But the changes the changes that are described in a structural damage will not change, will not improve till the nerve has grown all the way till the distal target organ. Therefore, there is no point repeating nerve conduction studies every few weeks. Also, nerve conduction studies will show lack of conduction only after 2 or 3 days. This the girl had fallen in her bathroom and had this laceration at the level of the medial epicondyle and had a deficit in the ulnar nerve territory. You can see that the FDP of the little finger isn't working, and there is a clawing of the ring and little fingers. And the Bouvier maneuver was positive. The nerve was found completely severed, but stimulation of the distal end continued to show contraction of the flexor carpi ulnaris. That is at 24 hours. Therefore, there is no point doing nerve conduction study on the day of the injury. Now, in a nerve conduction study, we are presented with a huge amount of figures in the numerals in the report, and we can't make head or tail of it. Just to simplify, we are going to test latency, amplitude, and waveform. Each of these get affected. If there is prolonged, so if there is a structural damage, either there would be a prolonged latency or no response. Since if there is a total shutdown of conduction, obviously the amplitude would be 0. And if there is a partial injury, so the conducting portions would show that portion of the wave, the waveform otherwise would get altered. But if there are some fascicles in continuity, the conduction velocity will remain normal. And therefore, you should not go by the NCV. One should go by the full report. Most often we say, oh, the EMG did not help us. Why does it not help us? Because it is either done too early, or we send a prescription which is incomprehensible. It doesn't give any information of the clinical condition, does not indicate which muscles we are interested in. And the EMG is done by technicians. The neurologist comes in the evening and just examines the graphs which are without having seen the patient. So what do we look for in the EMG report? What will signify denervation? You will see increased insertional activity. You will see, instead of static, this thing silent at rest, you will see fibrillations at rest, and there will be obviously no recruitment or interference. Now, if you see that in the report, that means there is structural damage, and therefore it is definitely not neuropraxia. And therefore, if either it is axonotmesis, in which case there would be recovery after a given delay, or if there is neurotomesis, there is absolutely no hope for spontaneous recovery. So how long should one wait? So just to give an example, let us take the radial nerve in the associated with the humerus shaft fracture. The first muscle beyond the spiral groove that gets innervated by the radial nerve is the brachioradialis. Ordinarily, in a middle third fracture humerus, the radial nerve is injured approximately 3 inches proximal to the branch to the brachioradialis. So we would expect to see recovery in the brachioradialis at around 4 months after the injury. On the other hand, if there is a penetrating injury across the course of a nerve, and if there is a partial or total deficit in the territory of the nerve, we must explore. So, for example, this patient had this wound on the anterolateral aspect of the leg, and only tibialis anterior function was preserved. This was the status of the common peroneal nerve. Both the superficial and the deep peroneal components were severed, whereas only the branch to the tibialis anterior stayed in continuity. This was a puncture stab injury on the anterolateral aspect of the elbow. The brachioradialis and ECI, brachioradialis was working. The rest of the radial nerve was not working. And this was the finding on exploration. Laceration on the anterior aspect of the forearm. Complete loss of median nerve function, except for the palmaris longus. The FDS isn't working. The FDP of the index finger isn't working. All right, the anterior intraosseous nerve had got preserved. And there was no FCR function. The median nerve was severed proximal to the origin of the branches to those nerves, distal to the origin of the anterior intraosseous nerve. The wound might be inconspicuous like this. This patient had fallen off a local train and was fixed for the radius ulnar fractures, and this tiny puncture wound was missed. The ulnar nerve deficit was conserved for 6 months and had to be grafted.
Sorry to interrupt, sir. You have 2 minutes left, sir.
Yeah, I'm on my last 2 slides.
Yes, sir.
So as far as iatrogenic injury is concerned, whenever we are operating, one must remember that the only structure we can damage without knowing about it is the peripheral nerve. Therefore, if there is a nerve in the vicinity, we must look for it and take care to identify it and then proceed with the rest of the surgical procedure and keep it under vision at all times. This is particularly true for the radial nerve in the arm and the anterolateral approach. Otherwise, any deficit, any unexpected deficit after surgery should be explored. Otherwise, this sort of situation will be missed. Those people who swear by closed interlocking nailing should remember that if there is the distal locking screw has gone through the radial nerve, there might be a partial deficit, and a partial deficit is a definite indication for exploration. This patient had a radial nerve deficit from the day of the injury, and yet the deficit was ignored for 10 months. And finally, this is a case which Parag will be talking about later, so I will not spend time on it. Thank you all for your attention.
Thank you, Dr. Anil Bhatia, sir. You almost answered all the questions. We really appreciate your one video on the injured nerve that you showed, and you stimulated the distal end of the ulnar nerve, which showed the FCU contraction. That gives us the now clear idea that there is no point doing the nerve conduction study in early cases. Sir, may I know from you, according to you, what is the only absolute indication to consider electrodiagnostic when you see a very frank clinically nerve injury?
Oof, are you talking about a closed injury or a penetrating wound?
Close injury, sir.
I would go by the history. If there is a history of a violent trauma and the nerve deficit fits that clinical history, and the only doubt I have is whether I should operate or wait, then I would do an EMG to, for example, an axillary nerve. If a person has fallen off a ladder, had a fracture dislocation of the shoulder, and has had a deficit of the axillary nerve for say 3.5 4 months, I might do an EMG of the posterior fibers of the deltoid in order to confirm that there is no reinnervation happening in the deltoid, and then based on the finding there, I would decide whether to operate or to wait further.
Yes, sir. Sir, is there any test or how to differentiate between neurotomesis and axonotmesis? Is it possible to differentiate between these two?
Yeah, currently our radiology friends are quite helpful in doing sonography, and the median and even the radial nerves, the fascicles can be followed till the site of injury, and they can give us fairly accurate visualization about the morphology of the fascicles. The history of the entire clinical situation has to be taken into account before we rely on the sonologist alone.
Okay.
Thank
you very much, sir. Yes, sir.
Dr. Anil Bhatt. This is a question from Dr. Shah of Bhatia Hospital. He says, on day one, on the first day when the injury has occurred, if the patient comes with a closed fracture, possibly of the humerus, can you tell whether the radial nerve palsy which has occurred is a neuropraxia, a neurotomesis or axonotmesis on day one?
I think I covered that during the. Is a question to me?
Yes,
Hello?
yes.
Yeah, I think I covered that during the talk. I was there on the first day. If there is a deficit and the nerve looks completely intact, and it is in essence a low velocity injury, not too comminuted a fracture. The integrity of the nerve documented during surgery is enough indication for us to wait.
So he's talking about a closed fracture, not operated, not opened up. An injury.
If there is a deficit before surgery, I would prefer to operate and take a look at the nerve.
But clinically, are you able to differentiate between the three types on clinical grounds on day one?
It would in a neurapraxia, usually the sensory deficit is not there. So, but then with a person with a mobile fracture, you're trying to evaluate for superficial radial nerve territory. I would not back myself on clinical evaluation on that.
You beautifully also explained why EMG and nerve conductions are not particularly helpful at particular times. Dr. Prajesh from Rajawadi Hospital asks, sir, can you actually give us a timeline when we should order an EMG or a nerve conduction study after any injury? Give us, should we order it 3 weeks, 3 months? When should we leave?
Most important thing always is the clinical situation. The history, what is the mode of injury, what are the fractures associated, which nerves are affected. Then if it is a violent trauma and you say that, okay, at 3 weeks following the accident, this is the deficit and this is a static deficit, this doesn't seem to be going anywhere, then the Valerian degeneration in that particular muscle can be documented. So you must have an interest in a particular muscle and indicate that you want an EMG of that muscle. Don't say EMG of the radial nerve. That doesn't give any clue to the person who is doing the test. And once you get increased insertional activity, fibrillations at rest in the territory of that peripheral nerve, automatically you should think either it is axonotmesis or neurotomesis and behave according to the clinical situation.
Right. Parag, thank you very much. We move on.
Thank you. Yes, sir. Thank you, Dr. Anil Bhatia, sir. May I request you to stop sharing your screen? Yes. I welcome Dr. Mukund Thatte, sir, now to give his talk on. Welcome, Dr. Mukund Thatte, sir. What to do and what not to do for an orthopedic surgeon. Yes.
Can you see my?
Yes, sir, we can see.
Can you see my screen?
Yes, sir. Yes, sir.
Okay. So this is the talk about some very basic things. Yeah. So I have been asked to talk about current techniques and what to do, what not to do. At the outset, I want to thank Dr. Zaveri and Parag Lad for giving me this opportunity in this Bombay Orthopedic Society webinar. These are my instructions from Dr. Parag Lad. He always gives instructions. Approach to different types of nerve injury, intra-op, partial or complete, how to deal with gaps, tissue glue and suture, and epidural or intrafascicular repair. Parag is always directing the show, as you can see in this picture, and usually is accompanied by a lot of young ladies. So the intraoperative approach. The approach is to completely diagnose the issue with the nerve. As Dr. Bhatia has pointed out, there can be a multiplicity of issues with the nerve. Always try to preserve the blood supply of the nerve. Ischemic nerve regenerates very poorly. So when you are handling a nerve, always look at the mesoneurium, and if you see a segmental blood vessel, try and not damage it. This is the picture showing the intrinsic and extrinsic blood supply of the nerve. In the left of your screen, you can see the median nerve with the median artery, and on the right, you can see a ulnar nerve showing its intrinsic network and a superficial nerve showing its segmental supply coming in externally. So these blood vessels should be maintained as far as possible. Once you diagnose an injury, the main question is whether you are going to do end-to-end repair or a nerve graft. There is no doubt that end-to-end is always the better repair. However, it should never be under tension. So the philosophy is like this. End-to-end repair only leads to one scar interface and therefore that much less loss of growing axons across the scar. A nerve graft leads to two scar interfaces and therefore more loss of graft of axons across the nerve graft. However, tension in an end-to-end repair causes huge amount of fibrosis and the advantage of end-to-end is then lost. How do I achieve this? I keep the joint in neutral and try one suture from 60 to 80 depending on the location of the nerve. Very small nerve, I'll try a 80. A large nerve like median, I will try a 60. If that suture is not holding in a neutral joint position, then I will not try an end-to-end repair. I will then graft it. Then there is this huge discussion on interfascicular, group fascicular, epineural, etc., etc. There was a time in the 80s and 90s when microsurgery was at its peak in discovering new things about nerve repair. Instruments were getting progressively better, microscopes were getting progressively better, and suture materials were becoming finer and finer, reaching up to 12-0 and nowadays 15-0. So some intrepid souls decided that they will do every fascicle to its fellow by drawing a map on the either side and then matching the fascicles. And they thought they are doing a better job. Well, at the end of 20 years, we now realize it was not such a great idea. In my opinion, it is now outdated. Few sutures plus tissue glue is, in my opinion, the correct answer. And the third line is important. Every suture is a foreign body granuloma leading to fibrosis. And therefore, every extra suture you put, more extra fibrosis you are causing. I will show you examples of both. So this is what we are talking about. We will excise that neuroma and repair the nerve. So this is an example, pseudo healing seen in the nerve. Median artery is interrupted, as you can see. This is the plan. Freshen up and do a repair end to end. So this is how it was. If you see this slide carefully, you will see some 10-0 sutures. And I had done a group fascicular repair to try and exactly match the fascicles. And then I had splintered it externally with an epidural closure of 80 nylon. And I got a good result. But this is not the point. This was a median nerve and you can see recovery of opposition. The point is you can get equally good result with very few sutures and tissue glue. I will
What happened?
I think he logged out. I think no, he's here still.
Sir has muted himself.
He muted himself.
Sir, can you unmute yourself?
Yeah. Okay. I have unmuted.
Can you start sharing screen again, please?
Yeah.
So were you not hearing anything or?
No, sir. We could hear everything. Suddenly the screen got.
Only the last slide. Only the last slide. You can go back a slide and start.
This slide?
Yes, sir.
Did you see this slide?
No, sir. The previous to this, the wrist level. We were at the wrist level.
So this was this one?
Yes, sir. Yes, sir.
Yes.
Were you here? So for this patient with group fascicular repair, I additionally did an epidural closure. And as you see, I got a good result. The opposition was restored in the end of 4 months. But now I don't do this. So now I'm showing you an example of what I do. This is a neuroma in continuity. We want to repair end to end after excising back to healthy ends. And as you can see, we have put, are you guys listening or is it gone?
Yes, sir. Yes, sir.
Hello, Parag?
Yes, we can listen you, sir.
Oh, I thought. Okay, so in this case, I have put 2 fine sutures of 9-0 over there. They are holding on their own. So after a few sutures, I'm going to put tissue glue, as you can see from that background, and you will still get the same result. and I have not done group fascicular repair anymore. So I would put 1, 2, 3 sutures depending on the size of the nerve, and the rest I would do with tissue glue. Another example, that's the musculocutaneous nerve, and these are the intercostal nerves. You put them together with each other, 1 or 2 sutures and tissue glue. So this is how you use tissue glue. So this is a nerve to triceps. Oh God, I'm sorry you won't see this because of my crash. I've moved to an Apple and now it's not playing. But anyway, these are examples of use of tissue glue, and I'm sorry about this.
Sir, because the bandwidth is poor.
Now what happens when you have a nerve? No, I had a codec issue, so never mind.
Okay.
Secondary repair with nerve graft, when you have a gap, am I okay, Parag? Hello?
Yes, sir. Yes, sir.
Parag, am I okay?
Yes, sir. Yes,
Sorry
sir.
about this.
No problem.
So this is a situation where I've had to excise a large amount of the nerve, and therefore I have a large gap of almost 5 centimeters. There is no way I can repair this end to end except perhaps by flexing the wrist 40 degrees, which is completely wrong and should never be done. So here we will do nerve grafts. And typically, if you do good quality nerve grafts and repair them adequately, you get a very good result. This is a 10-year follow-up of the same ulnar nerve. Partial injury is the most difficult. Often it is all within one neuroma, and the key is to use the highest magnification, separate out the fascicles in continuity, and then repair the remaining. And when I say highest magnification, really zoom in on the neuroma, because otherwise you will not be able to find out what is intact and what is partially injured. For our orthopedic audience, I am going to show you the most ideal case. This was a fracture radius ulna in a child, a green stick fracture. As you can see, there is a complete median palsy there. This is the level of the fracture, which is why the extrinsic muscles are working, because the median nerve is damaged a little distally. But the FPL and the index finger FDP was not working. And you see that arrow there. It was over there that the nerve was entrapped. I will show you. So this is how it was entrapped in the radius. It was in a bony tunnel which had been formed by the callus. Partly it was compression, partly it was a cut. And if you see it now, after we removed it from the tunnel, one arrow, the black arrow shows you the tunnel which had formed, and the white arrow shows the partial injury to the median nerve with some fascicles in continuity, which we then repaired and treated with tissue glue. And at 9-month follow-up, the patient both had palmar abduction as well as complete opposition. So in a partial injury, try to separate the fascicles, which you need very high level magnification and microsurgical skills to do this. So I would like to conclude by saying one must expose nerves well. You must diagnose the injury properly, repair the nerve either end to end or graft, that depends on the tension that is there. Do not put the joints in an abnormal position to get end to end, and less sutures plus tissue glue is ideal in a tension-free repair. I want to thank you for your attention.
Thank you very much, sir.
Sorry about the...
No, but we could hear the presentation well, sir. Sir, you mentioned that 40 degree of wrist flexion was required in one of your case to repair the nerve, and that was not right.
So I did use it.
Yeah. So how much flexion is permitted, and after some time, I mean, the nerve can, I mean, there is no risk of re-rupturing the nerve. So how much flexion will you consider?
Honestly, at the wrist and finger level, I will not consider any flexion.
Okay. And
at elbow level, I will consider a little bit. Let me give you an example, which was there in the ISS's discussion group. I recently did a case with fracture humerus, simultaneous injury of median nerve and radial nerve. The radial nerve had a huge gap. The median had a very small gap, which could be done end to end. Okay. Now, if I flex the elbow, I was getting the median nerve very easily, but the radial was just going apart. If I extended the elbow fully, I was not getting the median. I did a compromise by 30-degree elbow flexion. I got median end to end, and the radial was not going away too much. And at that point, I didn't did that. If I needed 90-degree elbow flexion to achieve the same, I would not have done it. Then I would have grafted both.
Okay, okay, sir. And sir, for an orthopedic surgeon, what suture material, like if I take an example of radial nerve, median and ulnar nerve, what suture material do you recommend to keep in our operation theater in case if we come across to such disaster? Or do you recommend them to consider repairing the nerve later?
Unless the person is trained in microsurgery and has spent at least 6 months in a unit doing microsurgery, the person should not do it, ideally speaking. You should be trained in doing microsurgery, otherwise you do more harm than good. I have several instances of orthopedic colleagues who deliberately do not repair the nerve, repair the rest, and just send the person to an appropriate center. And I salute them for doing it because they are achieving much better result by not fiddling with that nerve. However, if you're trained in microsurgery, you should have at least 9-0, 10-0 in your theater if you want to repair peripheral nerves properly.
Okay, thank you, sir. Dr. Amit Vyas has a question. Yes, Dr. Amit Vyas.
From the audience.
Suppose
From Pune asked Dr. Thatte that there are some newer chemicals, etc., which are now being used in order to stimulate nerve growth, etc. Is there any, what are the newer advances in this field in terms of growth, nerve repair, regeneration?
So my next talk, which is towards the end of the symposium, is on rehabilitation, where I've dealt with some of these points.
Right. Sure. Now the second question which he asked was, which comes from Dr. Fadnis from Yavatmal, and he asks you that in our place, often patients present very late after an injury, sometimes even 4 to 6 months after a CLW which has been sutured, and patient has a nerve injury. Now, till what time is nerve suturing still a valid option? If he comes at 6-8 months, should we directly consider a muscle transfer, or is nerve suturing still a valid option at that time?
So, Dr. Zaveri, the really correct answer is, how far is that nerve from its target muscle? So, the calculation is like this. The muscle is viable for 18 to 20 months. Let's say you came at 6 months, which means your muscle is now viable for 12 months. If your nerve injury is higher than 12 inches away from the target muscle, you are unlikely to get it, except in very small children. However, having said that, I would still repair the nerve for the sensory component. I do not wish to leave people without sensation for the rest of their life. So I would repair the nerve, but if, let's say, I do a high ulnar nerve mid-arm, and I am thinking of the intrinsics, they are never going to come. So I would do the ulnar nerve for FCU, FDP, and sensation, and I would do tendon transfer for intrinsic, or I would do a distal nerve transfer for the intrinsics, which is now described. Take the nerve to pronator quadratus and give it to the motor branch of the ulnar.
Yes. Sir,
So
will
you have to calculate the distance from the target muscle and see whether the original nerve will reach or a bypass will reach. Yeah, Parag?
Sir, will you consider distal nerve transfer and tendon
Parag, you're
transfer?
asking something.
Yeah, sir, will you consider distal nerve transfer or a tendon transfer in the same sitting of ulnar nerve repair or later?
No, never, never. If I am doing a distal nerve transfer, I am hoping to get my intrinsics back. In which case, why should I do a tendon transfer? Okay. If I don't get them back, I will do a tendon transfer.
Dr. Amit Vyas has a question. Yes, Dr. Amit Vyas.
Sir, suppose a situation is like that, at the wrist level, we are getting median nerve injury at 8 months, suppose. And at this time, you will prefer direct end-to-end repair with flexing wrist, or will you prefer grafting? because by doing end-to-end repair, we can buy the
So
time.
if the gap is large, I will still graft.
Okay. Thank you very much, sir.
Not really, Amit. Not really. At the most, you will buy 1 centimeter, 2 centimeters. It's not worth it.
Thank you. And Dr. Ajay Shah has given compliment to Dr. Mukund Thatte, sir. Very well presented and excellent results. Yes, sir. I thank Dr. Mukund Thatte, sir.
Actually, to Dr. Thatte Parag, before
Thank
you
you,
move
Dr.
on, sir, when you advise a patient, even when a neurosurgery surgeon or a plastic surgeon does a repair of the nerves, what do we advise the patient? What is the expectation?
Yeah.
In an acute injury, suppose there is an acute median nerve injury and you are suturing it, perfect technique, microsurgical, done by a plastic surgeon. What are the chances? What is the counseling that goes into the patient? I think Dr. Thatte we have lost him, but maybe Dr. Hari can answer the question before we move on. Dr. Hari?
Yes, sir, that's a very important question. And what we tell them that we have repaired the nerve, and the best of the literature and best of the repairs give only around 80 to 90% of the pre-injury level. But then the patient can do most of his activity. They won't realize it unless you do an objective scientific test of two-point discrimination and grip strength and sensory assessment. So functionally, it will be like near normal. But if you see objectively, the best of the results, in fact, I have one of my slides in my presentation. The best of the results in median nerve is considered as 80 to 85% of pre-injury status, even of the best of the results.
Right. Thank you very much, Hari. This is very encouraging for most orthopedic surgeons who feel that the results must be in the range of 30 to 40%. So 80% is a very, very good result. Thank you very much. I think, Parag, we can move on.
Yeah, now, without wasting time, I welcome Dr. Hari Ramani, Venkat Ramani, sir. He is going to present a case on axillary nerve injury in a near total amputation and how he has dealt with it. Welcome to Dr. Hari Venkat Ramani.
Thank you, Parag. And it's very nice that you have set this up. In fact, I have been learning already in the last two talks. And I just want to share a small thing about Parag. When I met Dr. Aymeric Lim, who is the head of NUH, and he mentioned me a long time back that, hey, you send me a very great guy. Thank you. First, I didn't realize whom he was mentioning. And that was Parag.
Thank you, sir.
Reputation in Singapore also. So Parag asked me to present on axillary nerve injury in open shoulder injuries, shoulder fractures and injuries. Closed injuries we already saw in case of the radial nerve and others. So let us quickly go to the case. And this is a young man, 22-year-old boy, and this is very common, especially in Mumbai and in our places also. They go at night and then they get into a manhole or some ditch and they fall down. But unfortunately, when he fell down, he had a major open injury. And most of the open injuries along the shoulder and especially scapulothoracic injuries also have a vascular component. So the key is that when they arrive to the hospital, if you see that this is sort of real time, we recorded 9:55 p.m. he has arrived to the hospital, and that's his injury. Most of the scapulothoracic dissociations, especially at the clavicle level, actually require mainly clavicle plating, but most of the time they exsanguinate sometime before they reach you, which is very unfortunate. And they are really, so when he presented to us, he was actually gasping. And then on arrival, immediately the first thing we did was to intubate him. And that is done in the operation theater. So the first thing we did was to take him straight into the operation theater and get him intubated. And this is the one most important thing which actually saved his life, because to keep the arrival to the hospital and on table time as low as possible is the most crucial part. All investigations, x-rays, even the fast, everything is done after we have sort of intubated and stabilized the patient. So this is a key to remember. And then once we have stabilized him, then we assess the nature and the level of injury. So here, if you see, it has practically gone at the scapulothoracic level and the roots of the brachial plexus are intact. So mainly it is an infraclavicular and just behind the clavicle sort of injury. and that's his X-ray. So luckily he didn't have any other injury in the chest. It was just a scapulothoracic dissociation. So once we have debrided it well, he required vein grafts. So the clavicle has been plated. So the arrow shows onto the clavicle. So you should not go to sort of doing a vessel repair or a nerve repair before stabilizing the skeleton. So this is very important. There is a sort of indication if they come late or when the hand is going sort of, you suspect that the distal muscles are going in rigor or ischemia. You can do a conduit, flow through conduit before you stabilize the shoulder. We have done that. But most important, I think the best way is quickly fix the clavicle. So you need an expert orthopedic backup. And in this case, the senior most orthopedic surgeon, Dr. Deen Dayalan, fixed this, and he really fixed it very fast. So once we have fixed the clavicle, the next is we assess the vascular injury. And if you see here, the axillary, the brachial artery, axillary and brachial artery, basically the axillary becomes brachial at the outer border of the the teres minor, the pectoralis minor, sorry. And then as the axillary artery, what we did was it needed a vein graft. So we quickly harvested a vein graft. Now at this stage, because the patient has come practically in shock, we have not able to assess any preoperative sensory or motor component or deficit. But then even though we have intubated, and in this case, relaxants were given, at the end of just before he comes out or when we need a top up, we can still stimulate it and see. So on stimulation, we found the median and ulnar nerve to be intact, which was good. And then we closed the wound. So now after closure, the limb was viable. We did fasciotomies distally, and that's a clavicle as fracture. So now I would like to ask Dr. Thatte sir and Dr. Anil Bhatia. So because Parag asked me to put forward this question. So the patient now lacks shoulder abduction and elbow flexion. And Dr. Bhatia already mentioned about the axillary nerve in his presentation. So at this level, the level 1, so practically in a scapulothoracic dissociation, the axillary nerve either goes at level 1 or level 2. So that's a level where it is injured. And at this level, it divides into the anterior and posterior branches. And this will be, of course, dealt with in the next talk. So the question is, what do we do primarily? Do you explore or try to figure out the nerve where it is injured, or and put a graft, or do a nerve graft and tendon transfer at a delayed stage? So if they can unmute themselves. Parag?
Yeah, Dr. Bhatia, Dr. Thatte sir. So I think Dr. Thatte sir is not here. You can.
I would then answer the question.
Yes, sir.
Primarily,
Hari, give me a chance.
Yeah, please. Anil is there. Yeah.
First and foremost, it's nice to see you. I've not seen you for a while.
Yes,
seen anyone for a while. But you had the clavicle open. This was the ideal opportunity to study the anatomy all the way from the proximal to distal. Secondly, you are showing the video of the patient standing. The rotator cuff, if it is innervated, you would not be able to judge it in the upright position. You would need to examine the patient lying down and show whether the supraspinatus is contracting or not. So the lack of abduction, which I will deal with in a minute when my turn comes. As far as the lack of elbow flexion is concerned, as I said, you had the plexus in front of you. You could have traced it from the C5, C6 all the way up to the musculocutaneous and determined what level the injury was. A retroclavicular or an infraclavicular injury is usually just below the level of the coracoid process. The injury was violent enough to tear the entire pectoralis major and disrupt the axillary artery. Therefore, most likely the musculocutaneous must have been ruptured at the entry into the coracobiceps. And that is the most common site of infraclavicular injury. The musculocutaneous also could have been easily explored at the same time. And it is a judgment call. If at the end of the stabilization you have all the ends ready, then one can do a nerve grafting. or you can do a nerve transfer at a later stage when everything is quiescent. The choice is up to the surgeon.
Right. That is, sir.
I think Thatte sir has a net connectivity issue. I think go ahead, Dr. Hari.
I have just come back. I have lost.
Oh, good.
I didn't see. I'm sorry.
Yes, sir. Sir.
So no, I didn't see the presentation. I'm sorry. Please go ahead.
So basically it's a primary, it's a scapulothoracic dissociation. That was the injury.
Yeah.
And clavicle plating. There was a very violent injury at the axilla level. The median ulnar nerve and the radial nerve, all three nerves are intact. We were able to stimulate. We did not explore the axillary nerve at that point. And then we did fasciotomies and the wound went on to heal. That's a clavicle healing. So this is him at 3 months follow-up.
Yeah.
When presented to us. Of course, this was done nearly 15 years back. So it's a long time now.
Yeah.
So now the question was, in primarily, whether we will do anything extra. Now, even if you see him in current, in modern time, and whether we will do, if explore when or later on grafting versus transfer of axillary nerve basically.
So in such a violent injury, I would not have explored the axillary nerve on day one.
Yes, sir.
I would have probably done a good electrophysiology at 4 weeks, and if showing bad result,
Yes,
I would have considered exploring it between 4 weeks and 8 weeks.
All right.
And musculocutaneous as well, right? The elbow is not flexing.
Yes. Musculocutaneous, of course, we were able to see that it was avulsed. As Dr. Bhatia sir said, it was avulsed from the coracoid region. So we could see an avulsed musculocutaneous nerve.
Yeah. So probably that was in the field of injury and probably could have been repaired at the same time.
Correct. So yes, so we did not do that at that point. So what we did subsequently was an Oberlin transfer, and that gave a good result for him in this case because it was lying right there. So we did Oberlin, and this was actually done the pre-Somsak era. So at that time we had just attended a meeting, I think Bombay meeting conducted by Dr. Bhatia, and it was a very nice meeting. And that is where we saw the Somsak transfer. Of course, this will be covered in the next presentation. And basically, what we did, we used the medial head in this particular patient and put it into the axillary nerve. And just for the sake, what we did is a posterior approach. So basically, identifying the axillary nerve and the branch of the radial nerve. So through the posterior approach, identifying the deltoid and the two heads of the triceps. Teres major is the differentiating point. And once we identify the axillary nerve, this is what we did. So we put it into the entire axillary nerve. Of course, it will be covered in the next presentation, anterior versus the posterior branch. And the Oberlin transfer. If you see the timeline, actually, as I mentioned, first we did Oberlin, and we were actually planning either a trapezius transfer or just leave him at that point. But then we were lucky that Somsak transfer, we saw it, and then we came back and did a Somsak transfer for him. And that's him. So that's his around 2-year follow-up. Of course, he did not develop so much of abduction because of his scarring in the shoulder also. And but of course the elbow flexion was quite very good. So that's I bring you greetings from our team. Thank you very much, and over to Parag.
Yeah, thank you very much, sir. And it was really sir, it was indeed a difficult case. And may I know opinion from Dr. Bhatia sir and Dr. Thatte sir? In such a near total amputation, will you consider nerve grafting as a first stage, or you will consider a tendon transfer later once the limb survival or viability is confirmed?
Can I answer?
Yes, sir, please.
So it will really depend on the stability of the patient and how bad the patient is and how bad the injury is. Typically, in an injury like this with huge amount of blood loss, patient in shock, I would probably not do primary repair except if I can see the stump of the musculocutaneous lying there, I might have done that, but axillary, I certainly would not have gone up.
Okay. Yeah. Dr. Bhatia, sir. Dr. Hari, sir, meanwhile, can you stop sharing your screen?
Yes, please. Done.
Yeah. May I invite Dr. Anil Bhatia, sir, to give his talk, and he is going to enlighten us about the anatomy of axillary nerve and what are the possible ways where it can get injured and how to deal with the infraclavicular portion or the axillary nerve injuries. Over to Dr. Bhatia, sir.
Thank you, Parag. Once again, actually I had been amiss in not thanking you for including me in this symposium. I have issues about the infraclavicular brachial plexus injuries, and I will. I think I covered them in my talk 3 days ago. But let's see about the axillary injuries. What I'm going to be talking about is closed traction injuries to the axillary nerve. We all know that brachial plexus injuries are most often after following falls of a two-wheeler, but there are other modes of injury like a heavy weight falling on the shoulder or a luxatio erecta when somebody is falling and hangs on to something on the way, or injuries in hyperextension or a conveyor belt injury, or falls when the shoulder is in abduction. Here, a different portion of the brachial plexus is vulnerable to closed traction. The skeletal injuries, unlike in a supraclavicular injury where you would see fractures of the transverse process of the vertebrae, here you would see fractures of the lateral end of the clavicle, upper end of the humerus, neck of the scapula as Hari showed, or a fracture dislocation of the shoulder. And the injury is essentially in abduction, external rotation. If we all know that an anterior dislocation of the shoulder happens in abduction and external rotation of the shoulder. And at that point, the musculocutaneous nerve is tented over the head of the humerus. And the axillary nerve is the only nerve which crosses obliquely across the abducted shoulder. So these two nerves are vulnerable to closed traction at the moment of impact. And an impact at a speed greater than 30 kilometers per hour is sufficient to break these nerves. So we are talking about an injury to the beyond the trunks, that is to the divisions or to the cords and the terminal branches of the brachial plexus, which are termed as the retroclavicular and infraclavicular portions of the brachial plexus. Now, examination of the deltoid is a bit dodgy, particularly in a slightly older individual when the shoulder is stiff. And there even sometimes the EMG of the deltoid 2 does not give us a clear picture. And when we are examining the patient, even from the back, we are not able to make out whether the deltoid is contracting. Whereas here the rotator cuff is working fine because the external rotation is preserved. So I was asked to explore the axillary nerve by my shoulder surgeon because he was going to deal with the shoulder. And I chose to explore it from the back. And once I stimulated the axillary nerve there, you could see the posterior fibers of the deltoid contracting very well. And therefore, the exploration was not really necessary. Mere manipulation of the shoulder would have sufficed. So where exactly is the axillary nerve? We generally approach it. This is I'm exposing it in normal anatomy just to show where the axillary nerve is located. The standard deltopectoral approach, here we go medial to the coracobiceps, unlike the shoulder surgeons who prefer to go lateral to the coracobiceps and approach the shoulder. Here I'm interested in the nerves. So the axillary fat pad is exposed and it is retracted. The first thing that we'll see is the lateral cord. When the lateral cord is pulled in front and you go lateral to the axillary artery, one can expose the posterior cord. And the posterior cord will continue distally to split into the radial nerve and the axillary nerve. And the axillary nerve will enter the quadrangular space like so. So that is the area that I'm talking about. And that is the place where it is entering the quadrangular space, where it is vulnerable to close traction. The other nerves which are other nerve which is important in an infraclavicular injury is the suprascapular nerve. The suprascapular nerve is tethered to the to the scapula at the suprascapular notch, and therefore a violent injury in an anteroposterior direction would pull the suprascapular nerve as it enters the rotator cuff. Loss of abduction would be because of loss of function of the rotator cuff as well as of the deltoid. Therefore, one should examine the patient lying down as well as standing, and I'll show you that as I go along, to document the function of the rotator cuff before deciding on the mode of exploration. It can be a violent injury like Hari just showed, with a direct impact on the front, the pectoralis major torn, the axillary artery thrombosed, and you can see the axillary nerve in the field lying pulled out at the quadrangular space. In my, this is an old slide. The current figure is 1128, and you can see that 16% are infraclavicular injuries. And in my database of infraclavicular injuries, the axillary nerve is second in terms of the peripheral nerves that are injured. Now, how do we examine the for deltoid paralysis when the rotator cuff is intact? My friend Bettelli has combined with Bassam from Mayo Clinic and others to describe a few tests. There is a swallowtail test where the patient is asked to keep this position, and if there is a lag in that position, it indicates deficit in deltoid function. Similarly, the deltoid extension lag test, one can hold the arm in that position and ask the patient to hold that position. If he cannot, there is a deltoid weakness. Bettelli himself has described this test of abduction and internal rotation, where the patient's arm is supported with abduction and with the shoulder in internal rotation. If you cannot hold that position, there is deltoid weakness. But I prefer to use this test. I hold the arm in abduction and then ask the patient to hold that position. I hold the arm in abduction and ask the patient to hold that position, and you can see the deltoid contracting well there. So most often these are injuries in abduction and external rotation associated with fracture dislocation of the shoulder. There might be a suprascapular nerve injury, or there might be a rotator cuff tear. The rotator cuff tear can be evaluated by the MRI or by a sonography, whereas an EMG of the infraspinatus would, which is relatively easy to do, would help us clinch the diagnosis of a suprascapular nerve injury. Now, the methods of repairing an axillary nerve could be either nerve grafting, that is when you have a proximal stump and a distal stump. This is an infraclavicular injury, and if you know how to explore the axillary nerve, you can find both stumps. Or you can do a nerve transfer. Now, Hari kept talking about the Somsak transfer. Somsak had visited us for that meeting in 2007. He's a very old friend of mine. And he had the name of the transfer from the radial nerve using the branch of the long head of the triceps for innervation of the deltoid is attributed to him because of his publication in December 2003. But I know for a fact that Bettelli was working on the same transfer, and his publication appeared a couple of months later in 2004. So to my mind, it is actually, I attribute it to both my friends, Jaime Bettelli and Somsak Shabingbong. And essentially, Somsak described it by the posterior approach, whereas Bettelli described it by the anterior approach. I prefer to use the long head branch in each case and innervate the terminal branch of the axillary nerve as it enters deltoid. Now, I'll show you a few examples of the case. This is cases of isolated axillary nerve injuries. That means no other injury. This patient had a function in the rotator cuff. He was at 6.5, 7 months from the accident. The deltoid could be seen wasted. you can see that the supraspinatus function was preserved. But external rotation was still weak. So infraspinatus hadn't recovered very well by then. The pectoralis major function was preserved. And you can see the deltoid was wasted and there was no contraction of the deltoid on attempted abduction. The distal radial nerve function was completely preserved. By the deltopectoral approach, the pectoralis minor being divided, you can see that the axillary nerve was thinned out at its origin from the posterior cord. And therefore, there was no proximal stump available for me to graft from. Otherwise, in such a young individual, I would have chosen grafting. So I did a nerve transfer. And this is the function at 20 months. And you can see the distinct contraction of the deltoid. I had not seen him for more than a year, but I called him back just for this talk. A more challenging injury is the combined axillary with a suprascapular nerve injury, which unfortunately, which is an injury I really hate because quite often the suprascapular nerve is pulled out from the suprascapular notch and no distal target nerve can be found. So you can see that this patient had complete loss of abduction and rotations. He was 3 months post-injury. It was an injury of the axillary plus suprascapular. I choose to explore. The distal end of the suprascapular now is found by the posterior approach beyond the suprascapular notch. And I bridged it to the proximal stump with the anterior approach with the nerve graft. This was the axillary nerve, which was ruptured at the entry into the quadrangular space. And I chose to do a nerve transfer for the axillary nerve. And this is the result at 4.5 years. Quite often they are combined with axillary plus musculocutaneous, and this is an injury which can be easily missed because you feel that because of the rotator cuff, the abduction is preserved, and because of the brachioradialis, elbow flexion is preserved. And the distal functions are present. But when you examine carefully, you find that the deltoid is wasted. And you can see that the patient was flexing the elbow using the brachioradialis and biceps was not contributing at all to the elbow flexion. So it was an injury of the musculocutaneous nerve and of the axillary nerve. And both were found ruptured just below the coracoid process in the deltopectoral groove. Since he was a young individual, I chose to graft both of them. This was a 12-month follow-up showing the flexion in supination. Yes, the brachioradialis is contributing, but you can see that the biceps is contracting well. Because of the COVID period, I have not seen him in the last seven months. So I got this video by WhatsApp, and you can see the distinct contraction of the deltoid in attempted abduction.
Sorry to interrupt you, sir. You have 1 minute left, sir.
Yeah, I'm in the last two cases. They again to reiterate the point about examination in lying down. This lady had wasting of the deltoid and lack of abduction. But when you examine lying down, you find that the supraspinatus is contracting. The axillary nerve was ruptured at the entry into the quadrangular space. Chose to do a nerve transfer. Come on. Oh dear, this video is not running. Anyway, I'll go on to the last. So we must have a high index of suspicion in violent injuries of the shoulder. Look for an EMG of the deltoid. early exploration if there's a violent injury. This patient had a non-union of the clavicle, and for 6 months he was being conserved. Again, a rupture of the axillary nerve grafting, and function. So about the debate about nerve transfer or nerve grafting, in a young individual and a defect less than 10 centimeters, I prefer to do nerve grafting. I have compared my series when I've done nerve grafting, this was the outcome. And when I done nerve transfer, this was the outcome. It is not statistically significant according to me. So I generally go by the play it by the year. Thank you very much.
Dr. Bhatia, this is Gautam. There is a question from Dr. Vartharaj from Vellore, and he asks you that, sir, as an orthopedic surgeon, I see axillary nerve injuries in 3 conditions. Number 1 is when there is a shoulder dislocation which is reduced or is being reduced. Number 2 is when there is an open reduction in internal fixation of a proximal humerus fracture. And number 3 is when there is a shoulder replacement. Following these 3 things, we see them post-operatively. So one is how do we prevent them in this case, and number 2 is if it's a post-operative situation like after a fracture or a dislocation or after a shoulder replacement surgery, how should I manage it?
See, as far as the post-trauma situations, it is difficult to have examined the deltoid at all before the surgery was performed. So whether the deficit in the deltoid was present before surgery or after surgery is difficult to judge. I have given the location of the axillary nerve. If one feels confident about exploring the axillary nerve, it is a fairly straightforward approach after dividing the pectoralis minor. As far as the shoulder replacement part is concerned, a hemi replacement of the shoulder automatically excludes rotator cuff function. Therefore, innervating the deltoid after doing a hemi replacement is pointless. Whereas if you are the current reverse shoulder prosthesis, the rotator cuff function is not necessary, and therefore exploration and reconstruction of the axillary nerve, maybe by a nerve transfer, would be worthwhile.
Thank you. If there are no questions, I would request Dr. Bhatia sir to stop sharing his screen, and I welcome Dr. Amit Vyas. He is going to present a case on humerus fracture with radial nerve palsy. Meanwhile, he starts his presentation. May I ask Dr. Bhatia sir a question? Dr. Amit Vyas, please upload your presentation and share your screen. Okay. Sir, what approach do you use mainly? Axillary approach, deltopectoral approach, or a posterior approach?
For what?
For axillary nerve reconstruction, for nerve transfer. Nerve grafting.
As a matter of principle, in an infraclavicular injury, I always go to document the lesion. And therefore, since I know that the injury is going to be in the quadrangular space most often, I would like to go from the normal to abnormal, and therefore explore the posterior cord by the deltopectoral approach and trace it distally, identify the axillary nerve and trace it distally, and usually the broken end pops out in your hand. It is usually adherent. The only tricky part there is the circumflex humeral vessel, which there might be fibrosis around the circumflex humeral artery, and that can make the dissection slightly challenging because the deltopectoral approach is quite a cramped approach. The pectoralis major is intact, and it usually prevents retraction. Therefore, that can be a bit of an issue. Axillary approach would be very tough because the circumflex humeral artery comes in front of the axillary nerve when you're going by the axillary approach. Therefore, if there is fibrosis around that particular artery, I would not like to go it from the axillary approach. Although I have always preferred the axillary approach for the infraclavicular injuries otherwise.
Thank you, sir. Thank you. Yes, Dr. Amit Vyas, please start sharing your screen.
Thank you, Parag, for the opportunity. I would request all the faculty to please start their videos. So, because I have questions for all faculty. So, this is 43 years old male, had humerus fracture on left side after his auto
No,
rickshaw.
we are not able to see, Dr. Amit Vyas, we are not able to see your screen.
Okay, sorry. Are you seeing it now?
Yes, 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 very clear.
Okay. So this 40-year-old male had humerus fracture on left side. His auto rickshaw was toppled down, and it was fixed with narrow DCP by routine trauma surgeon. So my first question to Dr. Amit Varade, can you tell the clinical examination for screening of nerve injuries in upper limb trauma? Rapid screening. Dr. Amit Varade?
Yes. You mean you mean about this case, radial nerve palsy?
And it means in the busy practice of orthopedician, they are getting too many cases. So rapidly, how to screen?
First, we have to suspect which nerve is injured. So, in this case of humerus fracture, most likely nerve injured is radial nerve. So, first, first we should test the tricep muscle, then wrist extension and finger extension. Okay.
Very good. Very nice point enumerated by Amit Varade. So quickly, thank you, Amit.
Yeah.
We will recommend this OK test, V test, and thumbs up sign. OK sign for the median nerve, V sign for the ulnar nerve, and thumb sign for the radial nerve. So these quickly can be tested, and we can screen for the nerve injuries. So I would ask Dr. Hemant Patankar, sir. Sir, which type of humerus fracture will alarm you about the radial nerve injuries, and what is the role of documentation?
Yeah, it's very important because we must document the state of the radial nerve immediately as soon as we see a patient of fracture humerus or the lower part of the humerus or proximal humerus or the radial head fracture, distal humerus or radial head fracture. We must document the state of the radial nerve clinically, and we must record it and show the patient that his thumb or the wrist and thumb and fingers are extending or not extending. That we have to show it to the patient, his relatives, and we have to write it on paper. If possible, take a video in current situation.
So very well point. So just for the audience, as told by sir also, we should highly take suspicion when there is comminuted fracture of the upper 2/3, 1/3 fracture of the humerus, and whenever there is posterior and lateral displacement of the humerus, then these are the cases where radial nerve injury are most commonly going to happen. So the same case he presented at 3 weeks with the wrist drop. On the examination, his triceps was grade 5. Brachioradialis, ECRL, ECRB, ECU were grade 0. All EDC or extensor muscles were not acting. There was sensory loss over the dorsum of the first web. Median and ulnar nerve was okay. So my question to Dr. Anil Bhatt, sir, if this case present to you at 1 month, how you will proceed in this case? Or you need any additional information for that?
Amit, most of these closed injuries, we assume they are either neuropraxia or axonotmesis kind of an injury. So if it's a neuropraxia, it should have recovered by now, usually 3 to 6 weeks at the most. But then otherwise, if it's a kind of a stretch kind of an injury, it's probably an axonotmesis. So I would wait. I will probably get my nerve conduction studies done. Wait for at least 3 weeks. That's the minimum period we give. So by about 4 weeks, as you said, the first investigation would be a nerve conduction study. And of course, splint the patient, at least give us a static splint. And also teach him how to mobilize his wrist and fingers passively by himself. He can do, and then probably take a call after we get the nerve conduction studies. And if at all there are any other indicators that the nerve can be probably injured during plating and other things, I would also get an ultrasound done to see where the nerve is lying and document that.
Yes, sir. Very well. Main point is that, as sir told, that ultrasonography can show very early what the condition of the nerve, especially if it is entrapped and it is divided. So, question to Dr. Vipin. As sir told that we will wait for the recovery. So, what type of physiotherapy and what type of splint you will advise?
Basically, Amit, in this case of radial nerve palsy, I would give a wrist cock-up splint, and I would ask the patient to remove the splint and mobilize the wrist, and also mobilize the fingers. The mobilization of fingers is very important. The important thing about the cock-up splint is that you should give the splint only till the MCP crease, because if you give it up to the fingers, the patient doesn't mobilize the finger and they come with a stiff finger at MCP joint, and we have to do something for the MCP joint. So important thing is that mobilization is important. Wrist drop can be prevented by the cock-up splint, which has to be removed and clean. The patient has to clean it every day.
Very good. Very, very nice point. So as Vipin told that we will give only short cock-up, this type of up to the MP joint only. And this type of dynamic splint may cause MP joint stiffness, so they can be avoided. So question to Dr. MRT, sir. Sir, in the same clinical scenario, the patient present at 4 months with the same neurological status. What will be your strategy to treat this type of cases?
Dr.
Thank
Mukul
you, Amit.
Devate, sir.
Yes.
I have unmuted, yeah. Thank you very much for the question. So the typical calculation is like this. If it's a spiral groove level injury, the first muscle to re-innervate from the radial is the brachioradialis. At 4 months, we should have at least electrophysiology or clinical evidence of brachioradialis re-innervating. If that is not the case, I will wait for at the most 1 or 2 months more, and then I will re-explore the patient.
Okay.
So brachioradialis is the key. And to find out about the brachioradialis, I want to request everybody, nerve conduction, EMG are not appropriate terms. Electrophysiology is the appropriate term. It encompasses everything. So I would do an electrophysiology at 4 months, and I would ask them to target the ECRL and the brachioradialis, because these are the first muscles to re-innervate.
Okay, you will see the renervation of the brachioradialis.
Correct.
So, as I told that he came with this NCS report, and there was loss of conductions in both sensory and motor type of conduction studies of radial nerve. So, question to Dr. Hari Venkatramani, sir. As I told that unfortunately this patient presented to me at 6 months with no recovery. How you will proceed now?
Yes, sir. So, Amit, it's a very important and nice question, because as Tate sir said, we also usually do, or most of the time patients have already done electrophysiology and they present to us. If there is absolutely no sign of recovery on the electrophysiology, then we will like to go ahead with tendon transfer. But if there is some recovery of brachioradialis and ECRL or ECRB, the first 3 to recover, then we will further wait. We have had occasions where in a closed fracture, up to 1 to 1.5 years later also, there is complete full recovery which has been seen. So if there is absolutely no recovery of brachioradialis ECRL at 6 months, and the EMG electrophysiology says there is no recovery, then and the patient wants quick recovery and quick mobilization, radial nerve tendon transfers has one of the best results. So we will not hesitate in doing a tendon transfer if there is absolutely no recovery. I think that will be our approach.
The point is well taken. anyone else, especially to Dr. Anil Bhatia sir? Is Dr. Anil Bhatia sir is with us?
Amit, can I ask a question to Dr. Hari?
Yes, sir.
Hari, will you not do the nerve exploration? Will you straight do a tendon transfer at 6 months?
No, 6 months we will not explore, sir. We have not explored nerves at 6 months of radial nerve pulse. Okay. So we have only two options. If it's a closed injury and the electrodiagnostic does not show any recovery, then we go ahead with tendon transfer. Because we will of course give the choice. I have in my presentation also one small child. Very rare occasions we have explored and done nerve graft or secondary reconstruction to give a good recovery. But again, once you do that, by the time they get finger recovery is very difficult or quite delayed. So better to do it because tendon transfers in radial now gives excellent results, and that's been our approach. And of course, Amit was trying to ask about distal nerve transfers. So we have done few, but somehow we are not happy with the distal nerve transfers results because invariably we have ended up doing a tendon transfer because the power was not sufficient enough. So
okay, sorry to interrupt, sir. Means you don't want to explore. Dr. Mukund Thatte, sir, I hope you want to explore the nerve, no?
Yes, I want to explore.
Sir, so this is the situation. I also explored the nerve. I found that a nerve was found divided. The proximal end was near the medial head of triceps, and distal end was once it enters into the brachioidalis. So, MRT sir, what will be your choice now? Or if
nerve grafting.
Nerve grafting.
To nerve grafting.
Nerve grafting, sir. Any to all faculty, if they have any other option?
Yeah, can I ask a question?
Transfers.
Tendon transfer.
Yeah.
Tendon transfer.
Too much time has been wasted already.
Yes.
Amit Vyas, you have 1 minute left, so I think
Okay.
little bit proceed.
I came across this literature published in Journal of Hand Surgery. They have approached a medial policy, means they have done the nerve grafting as well as some limited tendon transfer. So I used the same strategy and I did the nerve grafting for the radial nerve and pronated teres to ECRB transfer for the internal splinting. And even after 4 months, I was able to achieve good wrist extension, and I have taken chances now to recover. So I waited for 2 years, but somehow there was no recovery in the finger extensors. So question to Dr. Rohan, now what should be done?
Can you hear me?
Yes, Rohan.
Since everything else has recovered and the fingers have not recovered, so I would use a flexor of the wrist and transfer it for finger extensors.
Okay.
I can't see what the thumb motion.
Thumb is also not recovered.
Yes, then we could do if he has a palmar as long as we could do a PL to EPL.
PL to EPL, yes. So this is published by me only. We used various FCU and FCA transfer in various patients, and we found that especially in laborer patient, because he was a auto rickshaw driver, so we used FCR tendon transfer to renovate it EDC and then PL to EPL as shown by Rohan, and we are able to achieve this type of result: full extension of the finger, wrist, and also flexion at the wrist. So thank you very much.
Amit, it was really what was real. I mean, you presented in such a fantastic way, and you really involved all the faculty and their experience to share about the radial nerve, which is most commonly injured, and we deal with it. I thank you, and I now welcome Dr. Heman Patankar sir to give more elaboration and where else it could get injured in a upper limb humerus fracture. Dr. Heman Patankar, can you please start sharing your screen? Amit, please stop your screen sharing.
Yes, I have done.
Hello, Parag, am I visible? Parag?
Yes, you are.
Yes, sir. Very well.
Thank you.
Yes, sir.
Thank you, Gautam, Parag, and the Bombay Orthopedic Society for allowing me to share my slightly more different views on this radial nerve thing. I would, as Parag has instructed, I would speak on anatomy evaluation, epidemiology, prevention, and management of radial nerve injuries. As we all know, all orthopedic surgeons know that radial nerve injury means loss of extension, and loss of extension means either of the elbow, wrist, thumb, and fingers. Loss of extension of the elbow we hardly see, or we see very infrequently, but basically radial nerve means a motor injury, a motor loss. We are not very concerned or bothered with the sensory part of the radial nerve. As has been elaborated, it's a descendant of the posterior cord of the brachial plexus, and the radial nerve is known to get affected in 4 areas: proximal, very proximal level, behind the spiral groove traditionally, and on the lateral aspect of the humerus around the elbow, and in the supinator tunnel, that's the posterior interosseous nerve. All these 4 sites will present with different forms of motor loss or motor palsies. And radial nerve, as we all know, is very, very closely associated with these structures. One is the triceps, one is the humerus. Then we have to always think of the triceps, humerus, the intramuscular septum. These all points are important when we are dealing with the humerus in different approaches. That's the posterior approach, the lateral approach. Also, we must know that the radial nerve, when we crosses from the lateral aspect and goes into the anterior aspect of the elbow, to again descend into the posterior aspect of the forearm, it goes between the brachioradialis and the brachialis, and then it is closely related to the supinator and the arcade of Roche. And when we evaluate the radial nerve for the motor loss, we have to, as I've said, we have to evaluate for the elbow extension. That is the triceps muscle, triceps power, the wrist extensors. When we know that, now we know that the ACRB tendon is innervated quite lower down, quite distally. So initially at the level of the distal humerus, the ECRB may not be or may be involved, but the ECRL is working. At this time, the brachioradialis and the ECRL can be tested, and you can have a severe radial deviation of the wrist. But however, in all the cases of radial nerve palsy, the finger and thumb extension will be lost. So nowadays we divide it into 4 levels with functional implications. In all levels, the function of the thumb and the fingers will be lost with variable levels of proximal paralysis. And level 1 is infraclavicular, as has been shown by Anil and Hari, and that is at the beginning of the spiral groove. At this level, the elbow, wrist, and hand is affected. Traditionally, this is also known as a very high radial nerve palsy, and here it is also known as a crush palsy. You can also get these injuries because of missile injuries, shoulder dislocations, proximal humeral fractures, and axillary or proximal humeral tumors. Traditionally, there is a difference. If you study the literature, there is a difference between crush palsy and the Saturday night palsy. Saturday night palsy is as a result of sleeping over the humerus. Crush palsy is as a result of prolonged pressure or the proximal pressure over the axilla. So that's the difference. In level 2 injuries, they occur at the level of the spinal groove, that is proximal to the this outlet here. And here the elbow extension is spared because the lateral head and the long head of the triceps is already supplied. That's the injury. This is also traditionally has been named as a high radial nerve palsy. Here the triceps is spared, and you can have this. This is also called as a Saturday night palsy or a honeymoon palsy. You can injection palsies, which are a very important source of radial nerve palsies in India, or at least in our setups, are also occurring because of the injection in this area. Level 3 injuries are slightly tricky, slightly controversial, and physical examination, you will always get a wrist extension. But if you examine the wrist properly, you will find that the wrist is going into more of a ulnar radial deviation. So that means that the ECRL is working and ECRB is not working. And that occurs mainly if you take an anterolateral incision. That's a wrong approach or a wrong incision to go for a humerus plate, especially when you're dealing with a mid-shaft approach. Or else if you are going for it, identify the radial nerve first and then do the fixation. The radial nerve crosses this incision and you have to be very careful when you're doing this. And that's the level of the injury here. And this is Dr. Parag's case, and where the K-wire has been inserted in this manner and it has affected the radial nerve, and there is a neuroma here in continuity. So this requires excision of the neuroma and suturing of the nerve, as we will discuss later. Level 4 injuries are distal injuries at the level of the supinator or in the proximal part of the forearm, generally as a result of radial nerve or radial head fractures or the Monteggia dislocations, and they are distal to the ECRB branch. Here they will present with finger and thumb loss. Various other conditions can cause this. Just for as a schematic diagram, radial nerve can get affected at these 4 levels. And what is more important, or what is more important nowadays, is to examine for the ECRB supply. So we know that what part of the nerve is affected. You can, by clinical examination, you know which part of the nerve is affected generally. The common causes of nerve are in trauma. About 12% of humerus fractures are associated with radial nerve injuries. Compression injuries, Saturday night palsy, crush palsies, and injection palsy, again a very important part. And I think more source of litigation is there in India because of injections now. How to prevent it? Thorough knowledge of anatomy, tissue respect, observing a few cases from the seniors, because most of the injections are given by healthcare workers. Orthopedic surgeons hardly go and give the intramuscular injections. Even GPs, they should be told to not to give the injection in the posterior aspect of the arm, or injection more into the deltoid region, or if intramuscular injection is to be given, deep intragluteal on the lateral aspect of the upper part of the thigh. Attention to surgical technique and meticulous surgery is very important. Management, traditionally, the radial nerves have been managed, especially when surgery is not indicated or not to be done, is managed by expectant treatment or tendon transfers. There is a lot of controversy, lot of various opinions regarding nerve repairs, nerve grafting, conduits, and so many other things. These are the recent papers which are giving a lot of information on the radial nerve injuries. That's both of them are in the Journal of American Academy of Orthopedic Surgeons. These are the papers for your reference. In this paper, it says that observation and tendon transfers were and still are the mainstays of management. And this paper says that if patients are treated early within 3 weeks of surgical exploration and fracture repair, the recovery rate of radial nerve is 90%. So this is a considerable thought to be given to these 2 papers. This splint has been shown previously also, and I don't use this splint. Is a favorite splint given by the physiotherapist to the patient for radial nerve palsy. This is a very cumbersome splint. Most of the time, patient does not use this splint because he finds it very odd, looks very odd. Alternative to this splint is use the same wrist support. This is a static support for the wrist with a dynamic splint for the fingers. This is gives a very this is a low profile splint, very patient friendly, and of course you can use it along with a forearm plaster also, and you can see that the patient is using this hand with the splint for waiting for the nerve recovery. Traditionally we do the tendon transfers. Traditionally flexor carpi ulnaris was used, but nowadays we tend to use, or we like to use, the flexor carpi radialis tendon instead of the flexor carpi ulnaris for the digital extensors. Pronator teres has been used traditionally for the wrist extensors, and palmaris longus if available for the thumb extensor. FCU is too strong and excursion is too short for finger extension, and FCU is a primary ulnar stabilizer of the wrist, and which makes it more important to sacrifice. That's why Brand and Boyce have advocated the use of a flexor carpi radialis tendon. That's how we do it. This is a schematic diagram. for the use of the pronator teres. That mainly works as a tenodesis. The palmaris longus has to be, the EPL tendon has to be transferred on the volar aspect. Works very beautifully as an abductor and an extensor, and the flexor carpi radialis for the fingers. There's a short video showing the transfers. Parag, do I have time? The short video.
Yeah, go on, Hemant. Another 2 minutes for your talk to go.
Yeah, I'll finish. This shows the flexor carpi radialis. That's the palmaris longus. That's the radial artery and the radial nerve there. You have to take care of them and spare them. That's the pronator teres, which is attached to the lateral border of the radius, and that is identified. And you have to take a periosteal sleeve along with that, so that you get more length for attachment to the ECRB tendon. The tendon transfers for radial nerve palsy are probably the first transfers that we do in practice as an orthopedic surgeon. And to get the hang of tension, tissue tension, and suturing and the tendon transfer, this is the best transfer to do. Generally works very well in the hands of an average orthopedic surgeon. You identify, especially in for the palmaris longus, you have to identify and make sure that you are not nowhere near the median nerve. Make sure that you are cutting only the palmaris longus. Very important. Then identify these three recipient tendons. That's the ECRB. That's the extensor communis. And that's the EPL tendon, which has been cut proximally and brought out on the volar aspect. Yeah. So you suture it with appropriate tension and give a post-operative support for about 4 weeks, and then mobilize with a splint for 2 more weeks. You can ask the patient to undergo formal physiotherapy also. These are one example of a radial nerve palsy following a comminuted or crushed injury of the upper arm. So there was no point, or he had come very late with the palsy with an infected humerus. So I went for a tendon transfer right away, and that's the mobilization of the hand with the splint, and that's at 2 years post-op following a tendon transfer. That's another case with an infected non-union of the humerus. He was treated initially with a fixator, then plating, bone grafting, and a tendon transfer again. Because I think considering the financial status of the patients, I think it is better to be practical and opt or give the option of a tendon transfer right away. They recover very fast. Within 4 to 6 weeks, there is a recovery seen. Very important that radial nerve palsy following the removal of plate is a very important condition or a source of concern. And if plate removal is indicated, it has to be done with a lot of caution. Some few other conditions where radial primary exploration of the radial nerve may have to be done. That's the case of a stab wound where the radial nerve only was cut and that has been repaired. Another case here of a crush injury with an avulsion of the skin. Radial nerve initially stacked, waiting for the soft tissues to settle down, and then radial nerve can be repaired formally in this case. Here, the radial nerve is entrapped in the spiral groove following a fracture shaft of the humerus, is entrapped in the callus, and that was treated with a grafting. It is Dr. Anil Bhatt's case. Thank you. And another case where in the Holstein-Lewis fracture, the sharp fracture fragment has affected the radial nerve. This should be treated at the same time as the fixation of the fracture, and the radial nerve can be treated appropriately depending on the state of the radial nerve, either a neurolysis or the repair, as the case may be. Another very important site of injury of the radial nerve is a very proximal injury of the forearm, where the posterior interosseous nerve is affected. Here, the posterior interosseous nerve was repaired. Just a minute. Injection-related radial nerve palsies are quite common. This is a very good paper, very recent paper of 354 cases, where because of the litigation and the problems and the patient complaining all the time with the doctor, they don't take aggressive treatment or they don't take timely treatment, and precious time is wasted performing physiotherapy and other non-allopathic measures, and the denervation of the process starts or becomes very significant. Because it has been observed that induction palsies don't affect the nerve directly. There is a perineural fibrosis, and if proper or timely neurolysis is done, they recover very well. So like this, and this is the neurolysis done.
Dr. Patankar sir, may I request you to,
yeah. I thank you all for your attention.
Thank you.
Hemant Gautam here, there is a question from Dr. Argekar, and he asks you, what is your experience with radial nerve palsy after an anterolateral approach to humerus plating? And how can you avoid it?
In fact, anterolateral approach for the humerus is probably one of the worst approaches to for the radial nerve, because the radial nerve is not only it is bound down at the intramuscular or where it exits from the posterior aspect of the humerus. So you have to be very careful, especially there is no tourniquet in this condition. You have to be very careful, identify the radial nerve, see that your assistant does not apply any traction on that, or see that you are always looking at the radial nerve when you are approaching the bone for the radial nerve at this time. It's probably one of the worst things. Posterior approach is better, but if you can't do it, then you have to take care of the radial nerve before you approach the bone.
Right. The other question is from Dr. Bhavin Doshi. He asks you that if there is a fracture of the distal fourth of the humerus where you are doing an open reduction and plating, how do you take care of the radial nerve as it goes into the through the
If it's the distal fourth of the humerus, then you must know that that the radial nerve is already anterior. So your anterior retractor should be, or you don't put a spike anteriorly. Then you don't get, generally these are all traction palsies. I don't think no orthopedic surgeon will go and purposely cut the nerve, but you have to be very careful that you don't give traction on the nerve. And obviously, as Amit has said, you have to document the state of the nerve before you operate all these cases and show it to the patient in these cases. I think it's more of a surgical problem in these cases.
Right, thank you. One question for Amit. Amit, there is a question from Dr. Pagare, who asks you that, or Dr. Danish Sheikh, who says that can early exploration of a nerve reduce the need for a nerve grafting, because then the edges will not retract away, far away. So should you explore the nerve early rather than waiting to prevent the requirement for a nerve graft?
No, I think you should go early if you have the nerve injuries there and circumstances are favorable. You should explore the nerve and treat it as may be. Because one thing very important to remember is that the motor end plates of the muscle supplied by the radial nerve are quite close. So the recovery time is not very long as compared to ulnar nerve or median nerve. So most of the muscles are supplied around the elbow. So you will hardly take 4 to 5 months for recovery. So it is better to go for grafting or repair as the case may be.
Right. I think we are running out of time. Should we move on?
Yes, sir. I welcome Dr. Mohanty, sir, our President of Bombay Orthopedic Society, for this webinar. I hand over to Dr. Swapnil, and then he will invite Dr. Mohanty.
Yeah. Good morning to all the viewers. I think Dr. Mohanty may have just lost his line. No, he's there. Yeah. So we have some important announcements coming in after this very important session. So may I now request Dr. Mohanty, the Honorable President of the Bombay Orthopedic Society, to kindly address all the members. Over to Dr. Mohanty.
Yeah. Good morning, dear friends. A very warm welcome in the Sunday morning today. As you know, the weather has suddenly changed, and today we are feeling very warm. And first of all, let me thank all our esteemed faculty who have been present here today, both from Mumbai and from outside Mumbai, as well as both from orthopedics, as well as from outside orthopedic fraternity. And especially, Dr. Mukund Thate, who has been past president of the Plastic Surgery Association, and he has been has a long association with Bombay Orthopedics Society. Every course, in the hand course, in the dissection course, he is always there. Now, as you know, as we are entering unlock 4, that gradually we are, getting adjusted to our lifestyle as well as your professional life. And we are holding all these our meetings on online platform, and there is yet another feather in our cap that as Maharashtra Medical Council announced about the guidelines for getting the credit points. So we first of all we tried it's for orthopedic surgeons who are registered with Maharashtra Medical Council and who are members of Bombay Orthopedic Society. So there are some hitches here and there, so there will be some issues, but as we go on and in the next clinical meeting or in the master series, you will streamline those things gradually. So please bear with us with these problems. Next thing, one important announcement that before end of this academic year of Bombay Orthopedic Society, we have planned to hold our Western India Regional Orthopedic Conference WIROC, and we have rightly named it as WIROC Unlocked. So we'll hold it in the March from 19 to 21st of March 2021. And our two dynamic organizing secretaries, Dr. Mandar Agase and Dr. Satish Mutha, will be talking to you about for about 1 or 2 minutes after I talk about it. And now I wish this master series a great success. If there is any suggestions you want to make, please send a mail to our honorary secretary, Dr. Swapnil Kenny, or else in my personal email ID, drssmanti@hotmail.com. Thank you all. Thank you, and have a nice meeting. Now over to Dr. Mandar for WIROC announcement.
Thank you very much, sir. And thank you very much to Dr. Gautam Zaveri, sir, and Dr. Swapnil Kenny for allowing me to speak about this. So as we know, we have the Bombay Orthopedic Society, and it is at the forefront of everything. We have been at our homes for the last 6 months. We are waiting for this period to get over. We are waiting to meet all of us physically and not just across the screen. We want our life to become unlocked. And that is where we are going to have WIROC Unlocked. It is going to be on 19th to 21st of March in Mumbai. We have to welcome the new normal. It's going to be a physical conference in line with the new normal. We will be meticulously adhering to all safety norms. It should be a perfect blend of physical and virtual technology. As with all WIROCs before this, we will be learning from the most sought after teachers across the world, and there will be an ample opportunity to all of us to showcase our work. Come join us, let's unlock ourselves. Block these dates, 19th to 21st March 2021. This is the main organizing team. We have Dr. Mohanty and the two of us, our executive council, and basically the entire Bombay Orthopedic Society is going to be the organizing team. It is going to be our conference. Thank you so much.
Thank you very much, Mandar. And before we go on and continue with this meeting, one small announcement. As we are all very proud that this is probably one of the first meetings in Mumbai and in Maharashtra to be accredited by the Maharashtra Medical Council. And we've asked for a pre-registration just in case any of you or your friends have not been able to register. Kindly contact Mr. Vaibhav on the BOS helpline, which is 9833635436. I repeat, 9833635436. And I wish you all on behalf of the Bombay Orthopedic Society a wonderful session ahead. Thank you very much, Dr. Parag, and over to you again.
Yeah, now without wasting time, Dr. Kiran Ladkar, may I request you to start sharing your screen. Dr. Kiran will be presenting a case of ulnar nerve injury. Dr. Kiran, can you please share your screen, please?
Okay, am I audible?
Yes, yes, you are audible.
Yes. Am I visible?
Yes, very well.
At the outset, I would like to thank Bombay Orthopedic Society Managing Committee, especially Dr. Gautam Zaveri sir and Parag Lad for giving me the opportunity to present this case. This case in discussion is about post-corrective osteotomy ulnar nerve palsy. An osteotomy was done for malunited fracture supracondylar humerus. Yeah. This case is about a 9-year-old boy, right hand dominant. He presented with left hand hypoesthesia and clawing of the ring and little fingers. And he was at the state of 3 months post-corrective osteotomy, which was done for cubitus varus, presenting from malunited fracture supracondylar humerus. This was the injury picture, fall on the outstretched hand, and he sustained this fracture, which was treated in a cast, and he went on to have malunion and then gradually progressive cubitus varus. Now, around 9 months after the injury, since the cubitus varus was established, he was planned for deformity correction and lateral closing wedge osteotomy by lateral approach was done. And here is a Siam image of 2 parallel K-wires from lateral approach. Now, this is at the pre-osteotomy phase. That's 9 months after the injury. He has a cubitus varus deformity on the left elbow. This is the flexion and extension range of motion for this child. Post-osteotomy, the operating surgeon noticed ring and little finger having sensory deficit in the form of hypoesthesia. He waited for spontaneous recovery. Hypoesthesia persisted and gradual clawing of ring and little finger started to show up. At this juncture, can I ask Dr. Hemant Patinkar sir about his views on what could be the pattern of nerve injury in this child and which investigation he would like to consider? Dr. Hemant Patinkar sir. Hello.
Is Dr. Patankar here? Kiran, can you ask the question to another faculty?
Yeah. In that case, can I ask Dr. Hari Venkatramani's views that what could be the pattern of nerve injury in this child and which investigation you'd like to consider?
Yeah, Kiran, it is a very, very interesting thing. But ideally, if it is the ulnar nerve injury was noticed immediately, I think it should have been sort of explored immediately and not waited. We recently saw a child like this, and then the K-wire was actually compressing upon the nerve. So most of the time, if you find something immediate post-op, it is ideal to try to do it before the patient is discharged and not wait for spontaneous recovery, because it's been done and we know preoperatively it was intact. So in this case, ideally we will explore it and or at least do an ultrasound, because everything else is quite stable. So if you do an ultrasound, now with ultrasound we are able to know the nerve and in relation to the bone. And ulnar nerve is one of the nerves which is very amenable or very useful for ultrasound. So in fact, we have also started learning ultrasound now in our clinic. We've got a new ultrasound. So I think we should immediately do something and not wait for. That should be the first.
Interestingly, I was going to come to that question, that whether to explore immediately or wait for the spontaneous recovery. But since this child presented to me at 3 months stage, I had no option of exploring then and there. Operating surgeon was quite confident enough. About this pattern of nerve injury, since Dr. Anil Bhatia is there on board, can I ask him what could be the pattern of nerve injury? Dr. Anil Bhatia, sir?
I'm sorry, I have been out of the field for the last 20 minutes. I wasn't listening. I wasn't around. So I just joined back.
Yeah. So this boy is 9 years old boy, supracondylar fracture humerus. And after that, he went into malunion, cubitus varus deformity. He underwent lateral closing wedge osteotomy with 2 lateral parallel K-wires.
Right.
And after the corrective osteotomy, he started to have noticed ulnar nerve deficit from day 5 onwards. Operating surgeon waited for the spontaneous recovery of the ulnar nerve, but the hypoesthesia persisted and he started to show flaw in the ring and little fingers. So I'd like to have your views, sir. Now, Dr. Hari mentioned since ulnar nerve deficit was diagnosed, he should have explored then and there. But this child presented to me at 3 months, and this is the current status what he has.
See, at 3 months, if the FCU and FDP have not recovered, then there is absolutely no point in waiting. I would, if you need to document any thing before surgery, I would do a sonography of the ulnar nerve and then go ahead and explore.
Okay. Any role of electrodiagnostic, sir?
When when clinically there is no function in the FCU, if the FCU is innervated hardly an inch distal to the site of injury, and the in a 9-year-old, if spontaneous recovery was going to happen, it would have happened by 3 months.
Agree, sir.
So I would not waste any more time.
Yes, sir. So at this point, he came with this electrodiagnostic done by the parent surgeon, and EMG showed CMAP was absent in ulnar innervated muscles with denervation, and nerve conduction velocity showed decreased snap. Now, at this juncture, again, sir, Dr. Bhatia sir and Mukund Tatya sir, what could be the type of ulnar nerve injury, looking at the clinical and electrodiagnostic pattern, and your views on the treatment plan? Do we consent for possible nerve graft if we find on nerve exploration, and about views on transposition of the ulnar nerve?
So can I answer?
Yes, sir.
So I would, like everybody has agreed, I would explore this nerve immediately.
Yes, sir.
I personally feel that the K wire has probably gone through the nerve, and you will probably find a large neuroma in continuity. Since nothing has recovered, including FCU, I would not fiddle around with that neuroma. I would excise that neuroma and try to get an end-to-end. If ulnar anterior transposition is helping me to get end-to-end, I would definitely do it. If I'm getting end-to-end just like that, then I will not do transposition.
Bhatia, sir, your views, sir?
I would do a transposition nevertheless.
Okay, sir. So I did explore the ulnar nerve and anteriorly transposed it. And these are the clinical images pre-exploration. He had clawing of the ring and little fingers and hypothenar vesting on the left side. Now, this is the finding on the exploration. The ulnar nerve was found to be in continuity all throughout. There was a stretch just at the level or slightly distal to the medial epicondyle, and this was the point where the ulnar nerve was thinned out. About the wires injuring the nerve, we couldn't find any particular point where the ulnar nerve was injured proximally, and this is the area where the ulnar nerve was getting compressed against the medial epicondyle. Now, I did anterior transposition, started splinted for 2 weeks, and then after that elbow mobilization. I gave knuckle bender splints for the clawing, and patient interestingly went on to have gradual recovery. Sensory motor recovery happened completely over next 1 year, and this is the follow-up at 2 years. Now, during lockdown, his father sent me the video. If you can appreciate, there is a hypothenar bulk or the muscle bulk which has come up. There is overcorrection of the cubitus varus deformity, which probably correlates that ulnar nerve was getting stretched after the osteotomy, and that's why there was a nerve palsy. And we can see the recovery in the gradual video to come. Yeah, the clawing has disappeared.
Kiran, can I ask you a question?
Yes, sir.
No, there's in these cases with supracondylar fractures, there's always a complete different mechanism of injury and nerve entrapment, and always an explanation. We should not always probably think that the surgeon K wire is piercing it, because a lot of times supracondylar fractures, we do lateral pinning, which is the safest actually. So the malleolated supracondylar fractures, basically the nerve is kinked. when there is a cubitus varus, and there is a V-shaped kind of a kinking which happens especially when the child flexes the hand. But here, of course, the child didn't have any deficits preoperatively.
No, he
So as
didn't
you
have.
rightly said, probably a little amount of overcorrection might have caused the stretch, which the nerve already adhered there and a lot of fibrous tissue. And then the cubitus valgus correction which happens, the valgus correction which has happened is probably stretched the nerve.
Yes,
And
sir.
as you've rightly done, just the transposition is good enough. An ultrasound would have clearly told you exactly that the nerve is completely intact and there was no injury to the nerve through the K-wire itself. But that is the explanation you can think of, especially in supracondylar fractures with malunion, and then they later develop tardial nanopathy.
Yes, sir. Yeah.
Yeah. Thank you, Dr. Kiran. Dr. Rohan, can you have the last question for Dr. Kiran, and then we move on to the next talk?
Dr. Kiran, did you use intraoperative stimulation for the ulnar nerve so as
Right.
to find out whether there was any distal stimulation?
No, I didn't use that. But only thing clinically I could find the nerve in continuity. But that's one point which I haven't done, intraoperative nerve stimulation. And you asked about this pre-op USG. That also I didn't do it. I just went on with the clinical and the electrodiagnostic.
Thank you.
Yeah. So only take-home point which I would like to, as Dr. Anil Bhatt has also mentioned here, in this case, this nerve palsy is a known potential complication and overcorrection leading to, I would not say it's a tardy palsy, but it's a probably acute event, and which led to stretch on the ulnar nerve. And anterior transposition helped to, for this child to have his good amount of recovery in the ulnar nerve. Thank you. I thank everyone for kind attention.
Dr. Gautam, do we have any other question for Dr. Kiran, or should I? Okay. Dr. Kiran, thank you very much. Can you please stop sharing your screen? And I welcome Dr. Anil Bhatt now for giving us more elaborative talk on at what level the ulnar nerve can get injured. I welcome Dr. Anil Bhatt. He is the head of the department from KMC Manipal.
Is my screen seen?
No, not yet. Kiran, can you please unmute yourself? Both the devices? Yes, Dr. Bhatt, yes, we can see it now.
Thank you, Dr. Zaveri and Parag, for this opportunity, and the Bombay Orthopedic Society itself. And this is about ulnar nerve, which is called as the nerve of the hand. And as I just started looking at the course itself, I realized how such a long course it has, right from the nerve root itself till it goes to the enemy territory, which is basically the median nerve territory. So I've asked Parag to give me 5 minutes extra for this talk because there are a lot of areas which needs to be covered. And it's a beautiful nerve which controls the fine movements of the hand, and it's called as a musician's nerve. Now, clinically, for orthopedic surgeons, it basically presents with a claw hand or sometimes sensory or autonomic kind of a deficits. These are the ones which we commonly see. So a lot of causes which I'm telling at the end of the day basically presents with this kind of a picture. So when we ask the patient about what is their impairment of function, whether it's weakness or paralysis or loss of sensibility or alteration, and sometimes pain itself, and most important thing is to bring out the disability of the patient. And the disability of the patient here is this: the MCP joints which flex first, now in the normal cascade and normal movement, is lost, and the IP joints flex first. And this, what happens is basically that the grasping and pinching kind of activities reduce for the patient. So it's, and the intrinsics are obviously involved, so the fine movements are altered, and so patient can't pick up small objects or even grasp bigger objects. So this is one of the major disabilities. And in our country, people always tell that they can't mix the rice and they can't eat properly. So these are the disabilities which patient talks of. Now, as I said, etiology right from the root avulsions, it can cause a claw hand kind of a deformity in the neck area. Trauma, of course, there's a lot of compressive neuropathies involving the ulnar nerve, cubital tunnel, Guyans. Surgery related major chunk, especially near the elbow and the wrist, and of course, Hansen's in our country and sometimes tumors. Now, orthopedic surgeons basically would see them in acute onset, like in sometimes lateral condyle, medial condyle fractures, supracondylar fractures, or open elbow injuries like this, or sometimes like this, tardial now palsy, or kind of a Hansen's kind of a presentation. So these are the usual presentations which we see. And the basic thing is you need to find out where is the pathology. Is it somewhere in the central or is it in the peripheral part, and what is the circuit which is damaged here? And if you don't find any major causes in the limb itself, always remember there could be some central causes like syringomyelia and Charcot-Marie-Tooth disease. So all orthopedic surgeons should be aware that some things in the spinal cord should be checked for a lot of times in these patients. The other one would be obviously the brachial plexus injury, the CAT1 kind of injuries. Fortunately, they're quite rare compared to other types of injuries, upper brachial plexus and the globals. So, but then they're always prone for avulsions. Narakas said 70% of these with root avulsions will have the lower roots avulsed in these kind of patients. And we all know about the classic clump case kind of a paralysis, which basically was described in children as birth palsies, but otherwise can be kind of a general term for lower brachial plexus injury. So whenever these are there, it's good that we refer these patients to people who are dealing with them daily, because the surgical anatomy in this area is quite complex, and these nerve roots are very close to the great vessels there and the lung, and it's quite inaccessible even for brachial plexus surgeons, and they would resort to most of the time to nerve transfers. The other thing all of us would come across is a thoracic outlet syndrome. A lot of times look for the dynamic component, because there could be a vascular kind of a component or a neural kind of a component. So these are generally managed non-operative. Very rarely an orthopedic surgeon would be called to excise the first rib or an accessory rib or decompress these areas. Now this nerve, once it comes out, it's got a kind of a lonely path. All the way it's the medial cord, it doesn't give any branches anywhere, and it enters the axilla here. And here, this medial leg of the M-shaped kind of a transformation which happens here between the medial and the lateral cords, that is where the nerve enters the axilla. And the importance here in the arm itself is this ulnar nerve is used a lot of times in upper brachial plexus injury with the classical what's called as oblique transfer, where the vesicles are used for biceps and for brachialis muscles innervation. So when Dr. Patankar was talking about radial humerus plating. So when these are there, when you're doing a humerus plating, you shouldn't be damaging any of these nerves, because we generally place the plate medially, even though it's anterolateral approach. So always talk to the surgeon who would be involved later for the nerve management. That's very, very important. The most common areas where an orthopedic surgeon would encounter these would be the elbows. We have the medial intermuscular septum, the arcade of Strudel, and basically the cubital tunnel itself. So the ulnar nerve piercing the medial intermuscular septum, this is where the things start for us during the elbow surgeries. And here you have the arcade of Strudel, basically a kind of a muscular, fibrous kind of an arch here between the triceps and the intermuscular septum, where the nerve is coming out here. And it can become a constriction during anterior transposition of the nerve. So you need to be very careful with this. And of course, as it enters the FCU here, and you have the Osborne's ligament, the classical area of constriction here. So this is the ligament coming in here, and the band of deep fascia between the two heads of the FCU, that is the Osborne's ligament. And cubital tunnel per se is evident, especially in flexion, where the tunnel pressure increases because of tightening of these fascia around it, and even the MCL coming into the picture. So there could be facial bands, soft tissue abnormalities like a hypertrophied synovium, ganglions, bony abnormalities, subluxation of the ulnar nerve over the medial condyle, and sometimes occupation related. Very commonly seen between the two heads of FCU. That's where the compression happens in cubital tunnel within the arcade of Strudel and between the Osborne's ligament. Patient comes usually with tingling and numbness. Most of the time, the symptoms are more in the hand rather than elbow itself. Weak grip, elbow pain occasionally. The features are basically more of a high ulnar nerve palsy if there is any motor deficit, tinel sign, elbow flexion test. When you flex the elbow for about 60 seconds, patient starts complaining of pain. When you put pressure here again, that is a provocation test, patient has pain. And you would see this kind of an ulnar paradox where high nerves causes less of a clawing here compared to a low kind of an injury, which causes more clawing because of the involvement of the long flexors in this situation. So always expose the patient adequately and look for proximal causes. As orthopedic surgeons, we would look for fractures and arthritis, old medial condyle non-unions, arthritis of elbow. NCB and EMG can be done, and I use USG extensively. So ulnar nerve is documented what's happening, especially dynamic status is very, very important. This is the normal ulnar nerve here. This is the FCU and the relationship of that here. Now, when you do a dynamic USG, you will see what's happening during the extension and during flexion. The nerve gets completely impinged here. So it's a very important finding, especially for cubital nerve. And this is the ulnar nerve compression here. Proximally, you see the swelling and then edema here, and then distally it is. So ultrasound becomes a very important tool here. Conservative most of the time is tried, but surgical could be just decompression, anterior transposition, or we can go for medial epicondylectomy. And you also need to think of patients coming back again and sometimes salvage procedures. Patient education, activity modification is probably one of the most important things for cubital tunnel. Some braces are used, and then steroid injection, basically no major difference. Nerve gliding exercise is a new modality of treatment for this. And most papers say that you need to give good amount of conservative treatment and exercise, especially education of the patient and activity modification is very, very important. The surgical management could be just decompression or transposition, and as I said, medial epicondylectomy could be open or endoscopic, and limited decompression. So it might miss other sites if you do just an in situ kind of a decompression like this. So all those structures which probably cause the constriction should be removed here. And sometimes on table, you need to check what is happening. Is it staying stable or not? If it is not so, then probably a flap to retain it could be done. And again, endoscopic ulnar nerve release has a place, has a valid option for patients with this kind of a situation. This is a video actually done during arthrolysis of the extrinsic stiffness. Actually, I'm just showing the video of how we go all the way to the intermuscular septum there to release that air. And as you come distally here, you need to release the Osborn's ligament here itself. And then you always come distally much more and then release the fascia between the FCU heads. And then you can transpose it subcutaneously here with some amount of fascia and the fat itself, and then put a couple of stitches so that you make sure it stays there. And then you make sure you see flex and extend, see how the nerve is completely relaxed here. So this is the basic procedure of anterior transposition. Various types of flaps are described to retain the nerve, a Eaton kind of flap like this, and sometimes a submuscular kind of an approach, but this is generally used for revision procedures. Epicondylectomy, especially if there are osteophytes or previous fractures, and you need to do an oblique kind of an osteotomy like this so that you make sure you retain the MCL portion of it. And overall management is always non-surgical as a primary thing for mild and moderate. And hypomobile nerve, then you can go for epicondylectomy or transposition. For persistent recurrent CPTS, patients do come with thickened nerves. Sometimes you have to do external neurolysis and definitely anterior transposition. And salvage procedures are basically tendon transfer. If the patient comes with persistent ulnar nerve dysfunction, then or sometimes distal transfers like this. Thrower's elbow is one for we see sometimes with elite athletes like this, chronic repetitive kind of this valgus and flexion at the elbow here, and you would see the valgus instability and snapping medial head of triceps and hypertrophic triceps here. Sometimes there could be anomalous muscles. The anconius epitrochlearis especially can be seen even in these patients like this, which is a muscle here and an anomalous muscle here, quite thick here, and it covers the entire Osborn's ligament area here and can cause compression of the nerve itself. Sometimes they can have ganglions like this of the nerve, can be nicely excised and neuralized. The nerve can be neuralized and decompressed. So again, throwing athletes, non-operative treatment, but otherwise they're refractory, then you need to do an ulnar nerve compression. Again, for orthopedic surgeons, very common heterogenic ulnar nerve injuries is supracondylar fractures itself. So medial pin, especially placement, is one of the risk factors here. And when patient flexes the elbow, it can cause constriction of the cubital tunnel itself and can cause unstable injury. And most of the people either prescribe an open kind of a technique like this, or sometimes a mini open technique. If you're putting a medial pin, visualize the nerve, make sure you retract it and then put in the nerve. So open or a mini technique allows fracture reduction under visual guidance, limits the risk of ulnar nerve injury. Direct visualization is very important. Using of a drill sleeve is very, very important if you're putting in a K-wire, and keep the elbow not flex too much, but less than 90 degrees. So these are the factors which will prevent the injury to the nerve itself. Now, if somebody already has an injury, then treatment strategies would be wait and watch, or get an ultrasound, do a nerve exploration, make sure you remove the medial pin. That is very, very important. Now, again, orthopedic surgeons deal with a lot of distal humerus fractures here. The position, usually we put them in lateral position. The approach is posterior, and we always release the nerve from the arcade of Struthers. But the dilemma is whether to transpose the nerve after your fixation. That is very, very important. So this study tells there's no significant difference in ulnar nerve symptoms or functional outcomes or complications treated by any of these methods, and it's all based on the surgeon. And the other paper says there's no significant advantage in anterior transposition. Actually, it might increase the symptoms because unclear is it because of fracture severity or iatrogenic injury or a post-surgical scarring, and especially discourage medial plate placement if you can make sure that the elbow is quite stable without it. Very important is to adequately mobilize the nerve with preservation of vascular supply with sufficient tunnel space within the facial flap while mobilizing the elbow for very good results. So the verdict basically is transpose the nerve if there is excess implant contact or excessive handling or traction during surgery. Make sure the blood supply and facial tunnel mobilization of the nerve is taken care of. If not, release the nerve at least 8 to 10 centimeters proximally to the medial epicondyle, but do not mobilize it, almost like an in situ kind of a thing. Open injuries, when we see these patients, sometimes you might have to repair and then transpose anteriorly, or sometimes we do have grafting here, and then you can get good results. A lot of times the only thing would be the function of adductor pollicis, because that is the last branch there going there. And so the techniques nowadays is we always, along with this, we do a distal transfer so that we get the function of the intrinsics quite fast. Another way is, again, for the adductor pollicis exclusively, we can do a distal transfer here, apart from the proximal kind of a nerve graft or repair itself. That's very, very important, so that you can get these functions back. If you come to the wrist, the topography is basically there is a dorsal sensory branch here, and then the nerve divides into deep branch and superficial branch here. And sometimes when you place the incisions in the palm, make sure it's in the line of the ring finger here, otherwise you might damage this cutaneous branch here. The second one is the dorsal sensory branch. When we are doing surgeries on this side for a ECU tendinitis or any of these fifth metacarpal fractures, CMC dislocations, all this dorsal sensory branch is a very sensitive branch here. So we need to make sure that they are retracted well. During wrist arthroscopy, again, this branch, sometimes it can divide into multiple branches here, especially we are putting in 6R portals, 6U portals. So we need to use shallow skin incision and make sure that these are preserved. Fractures and percutaneous spinning of ulnar styloid, LT joint, fifth metacarpal base, the reverse Bennett's kind of fractures. Make sure you do a mini dissection there and protect the nerve. The superficial branch goes to the digital aspects, but what is interesting is the deep motor branch here, which goes all the way till the adductor pollicis here. And one of the common injuries we see is the fracture of the hook of the hamate itself here, and laceration in the palm or dislocation of fourth and fifth CMC can cause this kind of injuries for the nerve. We also should remember, if your symptoms are not matching with your signs, you should always remember aberrant connections, which is very common with ulnar and median nerve. One is the Martin Gruber, which is in the forearm here. Other one is the Rishi-Kaneva kind of anastomosis, which is in the palm here. The other one is a Berrettini kind of anastomosis in the digital branches here. And the other one is Marianchi kind of anastomosis, which is a reverse where the ulnar nerve goes to the median nerve. So this kind of anomalous structures you should remember. One important thing is the Guyon's canal syndrome. Yeah, basically there is 3 zones here. One where it's combined here, then only the motor branch, and then the sensory superficial branch. So any of these symptoms can happen. They also say the deep motor branch will now further go into what's called as a piso-hamate kind of a tunnel here at this point.
Dr. Anil Bhatt, can you...
One more minute.
Yeah. Yes, thank you.
So we need to test the strength of the intrinsic versus extrinsic muscles in cubital tunnel. Of course, dorsal sensory branch is the one which is a differentiating point between cubital tunnel, and less clawing because it's high injury. This is how the dissection happens, and you can see the 3 zones here. And this is a ganglion in the Guyon's canal. This is the hook of the hamate fracture here where the deep branch is there. And this is, again, we had a foreign body kind of a injury here coming into the Guyon's canal. And this is, again, a blunt trauma with a lot of neurolysis here. Finally, when we look at the claw hand, basically we see the deformities, the web space kind of a wasting, the arch is lost. So the principles basically is, I won't go into the clinical test. All of us know about this, but we assess these patients with certain angles, assisted in the contracture angles, and we splint them initially, and then we go for what is called as static procedures like this capsulorrhaphy or a pulley advancement like this. Or sometimes we go for dynamic procedures, which are basically the tendon transfer. This is a lasso procedure which is done. And this is the Bunnell's procedure of FDS being used for extensor expansion. So in summary, the nerve takes a long course and hence susceptible to varied pathologies. It controls very fine movements of the hand and hence the disability is devastating. And it demands great skills for repair and reconstruction, especially of the hand, because all the intrinsics are involved in this. Thank you so much.
Thank you, Dr. Anil. Can you please stop sharing your screen? It was really excellent talk. Can I ask one question? When you consider a ulnar nerve decompression at the elbow level, and if you notice some fibrosis, do you do any interfascicular neurolysis or you just neuralize the nerve from outside?
Most literature have established that there's no role for any internal kind of a neurolysis. An external neurolysis is good enough, gives the same equivalent kind of results. And as long as you nicely transpose it and make sure the bed is fine, the new bed should be good. That is the most important thing. That's very, very important. There should be no constriction again, both proximally or distally. That's again very, very important. If you take care of these things, I think external neurolysis is good enough.
And how do you immobilize this patient post surgery, or you start mobilization immediately after anterior transposition?
Yeah, I would mobilize them I immobilize them just for the wound healing and then try to mobilize them with a splint as early as possible.
Thank you, Dr. Anil. Now, may I?
A couple of questions from the audience. Can I just put them to Dr. Bhatt? Dr. Bhatt, very difficult topic from a very long nerve. You have covered it very systematically. Thank you. There are 2-3 questions. Dr. Pinal from Surat asks you the question that, are the outcomes of ulnar nerve suturing very similar in terms of results to the results of radial nerve? Where radial nerve, they said that results are almost 80 to 90%. Are ulnar nerve outcomes also very good? And what about the outcomes of tendon transfers for ulnar nerve problems? What are the outcomes like for that?
Okay. So the first question is basically ulnar nerve is a mixed nerve compared to a radial nerve, which is predominantly a motor nerve. As Dr. Patinga said, we don't really worry about the sensory part. Here we also worry about the sensory part. It's not that only that, it also goes all the way there to innervate the intrinsics. Our main worry is the intrinsics always. So a nerve repair always gives good results as far as it's done properly in early stage and it has time for it to recover all the way here. But still, patients always complain of some amount of intrinsic weakness, even with the nerve recovery happens. So that's why the newer techniques of distal transfers have come in, early distal transfers, so that you try to target them much early compared to waiting for the mother nerve to come all the way down. That is one thing. In terms of tendon transfers, I think no tendon transfer gives all the functions back to the hand. So now you have patients where most of the tendon transfers talk about MCPs. So MCP, the claw is basically neutralized by getting the MCP flexion and this. Now there are functions of abduction, adduction, there are functions of adductors. So you need to address all these. Of course, there are procedures like Dr. Srinivasan's procedure and other procedures where these are addressed actually, where the abduction, adduction comes in, the intrinsic functions come in, and then even the adductors can be targeted separately. All these can be done, but the routine tendon transfers actually don't address all of the functions of the ulnar nerve loss. That is the problem with ulnar nerve.
Right. Another question is, how long a duration is considered tardy?
Tardy.
Yeah.
Well, if you're looking at acubitus valgus, a non-union lateral condyle, and then it's all patient symptoms and signs. If the patient is good with the cubitus valgus, there are enough patients without any symptoms at all. So it's all when they start developing the paresthesias, and then when they start, claw, definitely when they come, it's late already, definitely much, much later when they come with a motor deficit. But a lot of patients do complain of this. When they flex and extend the elbow, they start complaining of paresthesias and all. So those are things which we need to catch early for these patients. So we need to talk to them and catch them early for those kind of symptoms.
Dr. Shetty asks you that a personal question. He has a slipping ulnar nerve behind the elbow. Whenever he sits with his mobile phone like on his ear, he gets severe paresthesia and even along the inner two fingers. He has had an EMG nerve conduction study which shows a little bit of changes. Is he a candidate for an anterior transposition?
Don't wait till your nerve dies. That is my advice. Which means to say that if he's got a symptom and he knows it's subluxating, it needs to be addressed. Or he should stop using his mobile and start using only.
Right, because he says in extension the symptoms do disappear.
Correct. So it means that obviously the nerve is getting irritated in flexion and it is getting impinged somewhere. And that needs to be addressed. That needs to be checked where exactly happening. And I think if he's a surgeon, definitely he should take care of it early rather than waiting for it to go for a motor kind of a deficit.
Right. Thank you very much. I think
Thank you.
we can move on.
Yeah. Meanwhile, I request Dr. Amit Warade to share his screen, and Dr. Bipin, you can ask your last question to Dr. Anil Bhatt.
Wanted to ask you, do you do a EMG NCV inching studies in cubital tunnel? Hello.
You're talking of a sequential kind of study.
Yeah, to find out the exact area of compression, to find that before, if you don't want to transpose the nerve, but you want to only release that part of compression. In that case, we do the inching studies and just release that part. So in all cubital tunnels, you just release and clinically check if it is subluxating and then transpose, or you do a inching study to, what is your role idea on this?
For me, it's always an intraoperative decision. So do a decompression and check for intraoperative stability of this nerve. And that's very, very important. So I don't do the inching studies. I would do a good thorough ultrasound examination, a dynamic ultrasound, see where exactly the nerve is getting impinged. That would give me much more importance, because anything with NCV or I should be not telling NCV, sir will scold me. Electrophysiological studies means that it's not a one-time study. It should be a sequential study, right? You do it today and then you compare it after a month or 2 months or whatever. And second thing is, it's always it picks up things much earlier, or it might not pick up things if it is too small a sensory branch kind of a thing. So not very reliable in that sense. I would go intraop and ultrasound kind of a combination.
Thank you.
Okay, Dr. Amit. Thank you, Dr. Anil Bhatt. Dr. Amit Warade, he is from Nasik, practicing hand surgeon at Nasik with special interest in peripheral nerve and wrist. Please start your presentation.
Yeah, 1 minute. Yeah, can you see?
Yes, Dr. Amit, very well.
Yeah, thank you, Parag and Gautam sir, for giving this opportunity. I'll be presenting, I'll request all the faculty to start their videos because it is an interactive type of case. So I'll be presenting on nerve injury associated with fracture and skin loss. So this 28-year-old gentleman had injury to his right hand. Basically, his whole right upper limb was twisted in a steering wheel of car, and it was rotated 2-3 times, and he fell on the ground. And due to this, he had compartment syndrome of the forearm also. And he presented to me on the same day. X-ray wise, he had a fracture of the radius and ulnar, lower third. So he also had a fracture midshaft of the humerus, for which we did plating and which subsequently united. So I would like to ask Hari sir, how will you manage such injuries? And for the sake of viewers, can you quickly tell how what structures must be injured in this case, and how will you counsel with the patient?
Yes, Amit, it's a very difficult and an interesting case. So first of all, when you see this patient, it is very important that you clinically examine him. They will be complaining of severe pain, but you have to patiently tell the patient, I just want to check your nerve. If you don't check it now, then it will be very difficult. So we can talk to them first of all, and then give some pain relief, because you can't examine him with pain. And before giving a block in these patients, you ask them to flex and extend. Most of the time, if you rest the hand as you have put it on a green sheet, they can show the signs of any nerve injury or any, then you check the sensation. So the way you check the sensation, you touch the index finger on one side, the normal side first, and on this side. Then what we tell is, if that side is 10, then how much is this side? Most of the time, median nerve can be picked up and they say, I feel 7 or 6, or there is reduction in pain. If you see the posture of hand, the little and ring finger and the flexors most of the time will be intact in this situation. We are only suspecting median nerve. So depending on the level of injury, your suspicion should go to the median nerve. And if there is reduced sensation in this situation, preoperatively patient complains, then you should see the median nerve intraoperatively when you expose the fracture site. In our situation, most of the time our orthopedic colleagues, they will go for plating for both the radius and ulnar. So when they do plating, then we also have a look on the status of the median nerve.
Yeah, yes, sir. Thank you, sir. So we did fasciotomy of the forearm and debridement of the contaminated wound. There was a lot of mud inside the wound because he fell on the ground. So, and we found that FDS and FDP of the index and middle finger and FPL were completely divided, and median nerve was also completely divided, and the ends of the median nerve were crushed. So we did K-wire stabilization for distal radius and nailing for ulnar fracture, and repaired the FDP of the index and FPL tendon. And since it was not possible to approximate the ends of the median nerve, we have tagged the median nerve because there was open wound also. And due to this open wound, we have not done plating for the radius. So now I'd like to ask Mukund Datte sir, your approach for managing nerve injuries associated with loss of skin, and how early and late we can repair the nerves.
So thank you, Amit, for the question. As early as possible is the answer. So if you feel the wound is contaminated, like in your case with a skin which is questionable, you have done what ought to be done. You have fixed the fracture, you have repaired the tendons. I would re-enter the forearm in 4 weeks, as long as I have stable wound healing, and deal with the nerve.
Okay, thank you, sir. I would like to ask, in such cases, whether the level of nerve injury change your decision.
No, not really. I am quite willing to do primary nerve repair if I am not worried about contamination and skin loss.
Yeah.
If the injury is sharp, or if the skin flaps are looking completely healthy, I will do primary nerve repair. I will not do secondary.
Yeah,
but in a case like this, where you said you found mud inside and the skin was not healthy, then I would wait 4 weeks.
Yes. Thank you, sir. Actually, we did the same thing. This is the post-debridement picture, and it was possible to cover the nerve with the muscle. So we covered it, and after that we grafted with the skin graft. And due to the fear of infection, as Datte sir said, we waited for 1.5 months and explored the median nerve. So this is after 1.5 months. Now the gap is approximately around 4 centimeter, and ends of the nerve is also not looking good. So I'd like to ask Anil Bhatia sir, what will be your preferred choice for managing this gap of median nerve, and how you will decide on number of cable grafts? Is sir around? Okay.
Hello. Yeah. So there is no question about. I'm surprised that you did not opt for a flap cover, or to allow your future nerve graft to be covered properly, because now you are forced to take an incision along the margin of the skin graft, and then closure over the nerve grafts would become an issue. I would definitely opt for sural nerve grafting.
Okay.
The defect is very close to the target muscles. Therefore, addition of a nerve graft of with 2 suture lines will not be such an issue. we can expect a good result provided the grafts are well covered with good soft tissue.
Okay. And sir, how will you decide on number of cable grafts?
Oh, that is a difficult question to answer. There should be, you have to cover the entire surface. So it could be anywhere from 6 to 8 cables. You don't know.
Okay. Sir, one more question. Whenever you have a choice of taking nerve graft, so will you always prefer sural, or you can take the nerve graft from the adjacent side or the same limb?
I did not hear your question. Can you repeat it, please?
Yeah. Sir, whenever you want to make a choice for nerve graft, always you will prefer sural nerve, or you can just take nerve graft from the adjacent side on the same limb.
In a presence of a upper limb nerve injury, I do not like diminishing the sensation of in the territories of the remaining nerves. So I have no hesitation in taking the sural nerve.
Okay. Thank you, sir. So we did nerve graft as Bhatia sir said, and we use 3 cable grafts and repaired it with 8-0-ethylon. And this is the 4-year follow-up of the same patient. His thinner muscles has recovered nicely, and his sensations has also recovered. So take-home message is suspect nerve injury in such compound fracture cases, and debridement is the key to prevent infection, and skin cover is required before managing nerve injuries. And whenever we are always do not hesitate and put nerve grafts while bridging the nerve gaps. Thank you very much.
Dr. Amit Varade, Dr. Rohan wants to know what suture material did you use to tag the nerve ends?
So that time I use 6-0-ethylon.
Okay.
Dr. Varade, what about skin cover would you advise in such patients? Would you advise, since the nerve is directly below the skin and it is exposed and it will require, would you advise skin grafting? Would you advise a flap in these patients? What is the way to cover the wound?
Sir, ideally, as Bhatia sir said, we should cover it with flap. But since there was a lot of infection, and after debridement, I just wanted to keep that wound open. I have temporarily covered the nerve with the skin of the covered the nerve with the muscle and put a skin graft on that. But later on, it was well settled. So I thought I'll just keep this and do not replace it with the flap.
Yeah, that's fine. I think just a comment for the question. You have had good, the thing to remember is not necessarily the median nerve has to follow the straight line. If your graft is on the side, you can just go a little in a curving manner. Tendon grafts need to be in a straight line. Median nerve graft can be a little bit on the curving side, so you can still avoid. But yes, flap would have made a difference. But in this case, you have got a good skin graft and a good viable muscle covering it. So you escaped. So it's good.
Parag, can I make a comment?
Yes, please.
I think Amit has managed the case very well. Yeah. This comment is not about Amit, but I very sincerely feel that cases like this should be jointly done by plastic and orthopedic surgeons, because not all orthopedic surgeons are savvy about nerve grafts and microsurgery and flaps, which is not trying to diminish their abilities. But I think each specialty has some strengths and some weaknesses, and such cases are best done jointly unless you are a completely trained hand surgeon.
Yes. So the dictum we follow at Ganga is that we tell them you manage the fracture as if it is a closed fracture. Then we take care of the wound and you take care of the bone. So most of the, however contaminated it is, most of the time, I think 95% of the time, we go for internal fixation only, because we then go for a flap or we can take care of the soft tissue.
Okay.
Thank you. Dr. Gautam sir, any questions from audience, or I will move ahead?
I think you should move ahead. We are
okay. Okay. Yeah, Dr. Hari sir, yeah, please start your presentation.
Yes. So I think we come to the sort of the third of the big three. So this is what I put up, and being a Bombay orthopedic, I think is where the audience can very clearly sort of familiarize themselves with these three nerves. So we saw how complicated the ulnar nerve is and how simple the radial nerve is. And what I am going to cover is something in between. So the ulnar nerve, as you saw, is a complex nerve, a musician's hand, artistic hand. So it fits nicely with Amir Khan. And the radial nerve is full brawn, no sensation, and is easy to handle. And the tendon transfers are also good. But then the king of the three is in the center, and that's the median nerve. And we also saw what deficits we can get when we get the three nerve injuries. If somebody asks you what tendon nerve or what nerve you want to have in absence of the other two, I think median nerve is one of the nerves which you like to have, because that's what gives the eye of the hand. So just about the anatomy, commonly asked question, and this is one of the top questions in the European Board of Hand Surgery, and is that what is the root value? Because the median nerve comes from the lateral cord and the medial cord, there is always a concept that C5 is always part of median nerve. But if you read many literature, and I've read a lot of on this, on the root value, you will find that the C5 component in the median nerve is extremely less or practically none. So most of the time you will have starting from C6 and not C5. It innervates most of the flexor tendons of the hand and also of the forearm, except the FCU ulnar innervated tendons. And of course, in the intrinsics we saw in the previous presentation. The two things to remember in the sensory function is the palmar cutaneous and the digital cutaneous. The palmar cutaneous supplies the palm and the digital cutaneous supplies the fingers. And it is also called the eye of the hand, just like what was median of the ulnar nerve, the musician's hand. Median nerve is called the eye of the hand. And the reason why it is called the eye of the hand, because most of the sensory functions of the hand, we use the index and middle finger and also the thumb. And also to place the hand in this position, we need to have the flexors working, and which is the flexors which are innervated by the median nerve. The origin and the course is quite long, just like the ulnar nerve. So what we need to remember whenever we sort of study the anatomy of any nerve, we need to remember is easy to remember as a river. So for example, I have put a picture of Ganges. So we need to know the origin, which is Gangotri, and we need to know where it ends. That's the terminal part. If you visualize the nerve as it flows from the neck to the fingertip, you will find that you will be able to identify the problems as it goes distally. So the two areas where we need to remember, or where we always get into problem, is one in the elbow. There is hardly much injury of the median nerve, as we saw in the radial nerve previously in the arm up to the elbow. But elbow is a region where all three nerves can be involved, and commonly we get both ulnar and the median nerve at the elbow. The thing you see here, you need to know the relation of the median nerve with the biceps tendon and the axillary and the brachial artery. So this is what we need to keep in mind. And this area we should always, all of us should familiarize. All the three nerves, interestingly, as they cross the elbow crease, pass through the two heads of the muscle, the radial nerve through the supinator heads, the ulnar nerve through the two heads of FCU, and the median nerve between the two heads of the pronator teres. So that is quite interesting when we see the anatomy of all the three nerves. And as it goes into the forearm, the anterior interosseous nerve is given off quite early, and the distal part is mainly the sensory component which goes to the hand through the carpal tunnel. So this is the other area where we need to keep in mind, because most of the forearm fractures, as was nicely shown by Dr. Thatte in his case where he had a green stick fracture, there was a involvement of the median nerve. So you need to know in relation to the muscle, in relation to the soft tissue, and also in relation to the bone. And most of the anatomy which we learn is more or less is a vertical anatomy, or not a cross-sectional anatomy. So ideally, when we start reading, and it's a good lesson for all the young orthopedic surgeons, at every level, you should just cut across like a cross section and then visualize the bone, the soft tissue, the nerves, and the vessels. And that is the type of anatomy you should have in mind whenever you operate or whenever you do any surgery. And as it progresses into the hand, it basically supplies the 3.5 fingers. As we know, the ring finger is partly supplied by the median and the ulnar nerve. And this part of the anatomy is actually more of the sensory component. The thinner branch is given away earlier, and then it supplies the thinner muscles. And this is a nice drawing, which is just recently drawn by one of our senior registrars, Dr. Vigneshwaran. And this is available now in the ISSH site. And also it is available in many textbooks. So this is along with the anatomy in the cross section, we need to sort of roughly have this image in our mind. Even we can sort of download this image and keep it in our operation theater whenever we are exploring a nerve. And at every level, we need to know a rough pattern. So if you see here, the pattern at the arm is having more of sensory and very less motor. And as we go distally, you can see the motor component is extremely small and most of them is sensory. So the cross-sectional anatomy of the forearm, arm, and the wrist, and the cross-sectional anatomy of the nerve, both should be kept in mind when we go for exploration. Now coming to sensation, as I mentioned before, the median now only starts with the C6. So the thumb is C6, the middle finger is C7, the little finger is C8, and T1 goes more proximally along the ulnar half of the forearm. And if you see on the dorsum, you should remember that the median nerve goes right up to the PIP joint of index and middle finger. So the radial component, which is supplied by the radial cutaneous nerve, which has a root value of 6, 7, and 8, only supplies the first web space, and on the palmar dorsum of the hand on the extensor side. Now these connections which was mentioned, I just want to let you know that you don't need to know it in detail, but what you need to know is that this can always be present, and there is a very high incidence of connections both in the forearm and in the hand. In the hand, you can have two connections, that is Ricci canu and the Bertini connections. So one is basically a motor connection and one is a sensory. Why we need to know this is that even if you have, for example, an ulnar nerve injury, you may have a patient who will have sensation in the ring and little finger, and that could be through these connections. But what you need to remember is that though these connections are present, they are not functioning most of the time. So why? So this is what happens in the forearm, that is Martin Gruber, between the median and ulnar nerve. And the reverse is also present. So what you need to know, the significance of this connection is that sometimes your EMG can be misleading, because through these connections, you may find that the nerves, muscles distally are functioning. Sensory assessment can also be confusing at times, but then you can always compare it with the other side. But here you need to remember that the other side may not have the same sort of sensory and motor innervation. I will come to that. The reason is these connections are not a conduit, so they are not functioning. They are something like what we say in plastic surgery or in our flap surgery. It's like a conduit or like choke vessels. They are present, but they only start functioning in case of an injury. So if you have a tardy ulnar nerve palsy and there is a blockade somewhere around the forearm or the elbow, what will happen is that the ulnar nerve distally, as it goes down, will get a block. And once it get a block, they will start flowing through this conduit. So it's something like you need to go to, for example, South Bombay and the road is blocked. What you do when the traffic becomes choked, the traffic goes behind and takes another route and comes through. So these conduit or these connections only start functioning in case of an obstruction or in case of a pathological condition. The other thing is commonly misleading is that when we say we use terminologies like benediction hand or ape thumb, both are actually should not be used, or they are sort of misnomers, because the benediction hand originally, as you see on the left side, was by the first pope, and actually the pope was having ulnar nerve palsy. So he was trying to control his claw. So he was trying to control the claw using the thumb. And if you see here, the thumb FPL is intact and the middle finger is also is able to extend. Earlier, before this, the popes used to give what is called as a Volcan sign, and that was shown by Dr. Anil in his presentation. You cannot extend or create a gap in your finger because the ulnar nerve is paralyzed. And ape thumb is also sort of a misnomer, because in an ape, Basically, when they compared, actually a gorilla, a chimpanzee or a monkey's hand is far more developed than a human hand and can do more functions than a human hand. Basically, they have a short thumb. And the reason of that, because of that, they are not able to sort of abduct and bring it forward. So that should not be used. Basically, there is loss of intrinsics. So in median nerve, you need to basically know three conditions: a high median nerve, a low median nerve, and a pure anterior interosseous. So in a high median nerve, this is what you will have. You will have a pointing index because both the innervating, both the tendons are not working. You will have loss of FPM, and of course you will have loss of sensation. In a low median, you will have wasting of the thenar muscle and you will have loss of sensation. In an anterior interosseous nerve palsy, you will have pure motor palsy. There is no sensory component of the anterior interosseous nerve. So in an anterior interosseous palsy, you will have pure motor deficit. So where all it can be involved in the forearm, you can have a pronator syndrome, anterior interosseous nerve entrapment, and carpal tunnel syndrome. And I think all of us are familiar with compression neuropathy part. So now we see for how does the outcomes, this was asked in the previous presentation also. If you repair a clean cut median nerve, what will be your possible outcome? And then these are the four important criteria which they have found. So age more than 54, site of lesion more than 56 centimeters from the finger, and if there is a delay of more than 24 months, as we know, motor end plates are alive till 18 months. So beyond even 24 months, you can do it for sensory purpose alone, but for motor purpose, it is 18 months. And if there is a graft length, more longer the graft, outcome is poor. So keeping that in mind, we saw a couple of examples, and even in Amit previous case presentation, in an acute injury, it is always nice to debride it well and then do a primary repair, and you can get a near normal function. Again, I always say a near normal is that if you objectively study them and compare it to the opposite hand, there will be minor discrepancy and there will be minor deficits, but patient usually does not notice it. Now coming to how much wrist flexion can be kept to achieve a primary repair. So up to 30 degrees is what is mentioned. And then slowly what we do is we do a 30-degree wrist flexion. You can do it, but then that wrist has to be quickly brought down into a neutral position. So maybe at 10 days or 2 weeks interval, we do a stereal plastering and finally the splint is kept in neutral. So that's maximum is allowed. Unlike the anterior transposition of ulnar nerve and even the transposition of the radial nerve, where you can get up to 3 to 4 centimeters, you can sort of mobilize and get primary repair. In median nerve, that is not possible. So you can still get good outcome. But then when there is a gap which is more, and as was seen in the case presentation, we should always go for nerve grafting. And this is a slide which is a more than 25 years old. And this was a very striking slide because this was what Dr. Sabapathy presented in a meeting in 1996. And then this was what impressed me at that time was that there was good thenar recovery following nerve graft. And then, so we never hesitate. So how many cables to be put? This was also asked. So basically we try to take care of as many as possible. So if the gap is 4 centimeters and you need around 4 to 5, then you can take you can take the entire sural nerve and do it. And even good recovery of motor is also possible in very distal nerve grafting. This is a case of radial nerve palsy. This was discussed. And in radial nerve palsy, especially in children in acute situation, and when there is complete loss, we always go for grafting. And you can get a good recovery. In this case, as I said, it is a pure motor nerve. You can get a good recovery of the motor nerve. But when it comes to median and ulnar nerve injury with a similar level of injury, that is supracondylar fracture, median nerve, many times, if you get an immediate median nerve loss or preoperatively itself, there is a median nerve loss. In those cases, we never sort of go for closed reduction. Always it is nice to open it and see for yourself the status of the median nerve. And in this case, of course, he had a brachial artery also, which was repaired, but the median nerve, as you see here, was stuck in the fracture site, which was relieved, and then near normal function was achieved. Now,
sir, you have 1 minute, sir.
Yeah. An example to show that even in high level, you can get good median nerve recovery. So this is a replant. When you are not able to primarily repair, you tunnel it, bring it proximally, and then go for secondary reconstruction. So this is a secondary reconstruction, and you can get a good recovery at 2-year follow-up. Soft tissue cover is extremely important. So primarily what we do, we debride it well, do a primary internal fixation, go for soft tissue cover, and commit usually at 2 months to 2.5 months time, and do a nerve grafting and tendon transfer. Long segment grafts, we can put it at the elbow and then go for distal tendon transfer. So this can be combined. As I said, at elbow level, if you graft it, getting intrinsic recovery is poor. This is again an example of soft tissue cover. Achieve soft tissue cover, then tendon grafts for the extensor tendon and the flexor tendon and the nerve graft for median nerve. Finally, in a forearm fracture with Volkmann's ischemic contracture, go for thorough debridement, soft tissue cover, and then we can combine median and ulnar nerve grafting at the same sitting along with the functioning muscle transfer. And that's the result we can get at the end of 6 months follow-up. And as the sensation improves, in children, we have also found they still can get some amount of intrinsic outcome. If intrinsics don't develop after a functioning muscle transfer, we can go step in at 1 year time and do a tendon transfer for intrinsic correction. Finally, how do we restore sensation? You can use the dorsal cutaneous branch of the ulnar nerve and connect it to the digital nerve, and thereby you can get distal nerve, or what is called sensory neurotization of the median nerve. Sensory re-education is extremely important. This is what we get. So in a median nerve injury, the patient will perceive like this. With the best repair, what you get is a picture on the right side. But then with intense physiotherapy and sensory re-education, they can start feeling and they can start going back to normal. So finally, peripheral nerve surgery is the last frontier in hand surgery. And I think this kind of educational activity can sort of improve our knowledge as well as make us take proper decisions when we face such situation. Thank you very much.
Thank you, Dr. Hari. That was a wonderful talk. There is a question from Dr. Mehta in Ghatkopar, and he asks you whether nerve injury, if there is a nerve injury, direct suturing versus a nerve graft, are the results different?
Yeah, definitely the graft results are considered suboptimal as compared to direct repair. But then a direct repair under tension is always will give actually a bad result as compared to, because if you stretch the graft beyond, whenever there is a stretch beyond 15 degrees or 15%, there is reduction in the blood supply of the nerve. So more than 50% blood supply reduces, and that can give to suboptimal results. So pulling it and suturing gives a suboptimal result, but a direct repair without tension will give a better result than a graft.
Suppose the median nerve you've put in, you've directly sutured, you've given a flexion about 25 degrees post-operatively. What is the process of mobilization post-operatively? When can you start dorsiflexing the wrist?
So usually most of the nerves, when we do combine also with tendon injuries, nerves after 1 week to 10 days time can start gliding. So they won't rupture if you've done a good repair. So what we do is at 10 days time, we start a little bit stretching and start from 30 degrees, we just make it to neutral at 10 days interval. And then maybe in 3 months time, they can go for full dorsiflexion. You need to protect them at least for 6 weeks.
Right, thank you. Any questions from any of the other panelists for Dr. Hari?
Sir, there is one question from Dr. Prakash that do you reverse the sural graft or you use it in the same direction?
Yeah, that's a very interesting question and keeps coming up for discussion all the time. We reverse it, and the reason being the branches coming out. But when you are putting it for, say, for example, you are putting 4 centimeters cables, that is a groove fascicular repair, then as such, it doesn't make a great difference. Because the concept of reversing was that if there is a branch coming out, the axons may come out. But now we know that most of the nerve repair is basically because of neurotropic and neurotrophic factors. And it is more of chemically mediated passage of the axons. So as such, it is not necessary.
And thank you, Hari. We've finished the big three, that is what Hari called them. And so from there, we move to smaller things, and we've got our younger generation now taking over. And we've got Parag Lad coming over to present a case of CLW on the hand.
Yeah, thank you, Dr. Gautam sir. I am very sure this kind of presentation, patients coming with this kind of presentation at least 1 or twice in a month in our routine orthopedic or hand surgery OPD. So I would like to present a case of 38-year-old female who had sharp object injury to hypothenar aspect of the right palm, and she presented 3 days post suturing. The suturing was done by family physician, and her main complaint was inability to flex little finger, and sensory deficit and ulnar aspect of the ring finger. So
for complete 1 year, because the impact factor is calculated for the entire year. So January 1st to December 31st is the time for that particular.
Dr. Hari Venkatramani, can you please unmute?
Get the impact factor or citations. If it is coming on 31st, it is counted that year, but it is has no chance. So what we are going to start is to start off.
Dr. Rohan, can you please call Dr. Hari?
One.
Yeah. Okay. So my now question to Dr. Anil Bhatia sir, that patient has presented to us 3 days post injury. Would you like to consider any investigation, ultrasound or MRI, or you would like to advise direct exploration?
You have to operate.
Yes, sir. So
There is no question. I will not waste time doing this again.
Yeah, the reason for asking this question, may I know, Dr. Rohan, your input?
Like Dr. Bhatia sir said, I would explore early because she has definitely a tendon injury, and probably with examination, there is a nerve injury as well.
Yeah, so even I considered direct exploration, but if this would have, because now the only mismatch finding in this case is the tendon injuries have happened to little finger and suspected nerve injury has happened to ring finger. So that's why there is we can consider local ultrasound to confirm our diagnosis, but I did not do any investigation. We advise for direct exploration and identifying the structures. And this is called Brunner's approach, and this is how we take this is how we do a zigzag incision on the hand so that we can extend our approach to look for the proximal and distal cut end of the structure. And these were the cut ends of the flexor, the little finger, both flexor digitorum superficialis and flexor digitorum profundus, they both were ruptured. And these were the two cut ends of the nerve, and this was the distal end of the ring finger nerve, and this was the proximal end of the ring finger nerve. I don't have exact photograph of showing intact nerves of the little finger, but trust me, they were intact. And both FDS and FDP tendons were repaired with modified Kessler technique, and ulnar digital nerve of ring finger was found completely ruptured, and the ulnar aspect of little finger distal neurovascular bundle was intact. And this was the intraoperative nerve repair. May I ask now question to Dr. Anil Bhatt, whether will you consider a tissue glue or will you consider a suture 8090, or which number of suture would you prefer for this repair technique?
You're very distal and it's a very small area of nerve. So I would just put a couple of sutures and just hold on to it. If it's a big nerve where you want to save time and everything, then tissue glue plus the suture would come in. But here you would do a nice repair of the nerve, and you also have the tendon along with you, right? You want to mobilize them also. So I would rely more on suture rather than just a tissue glue.
Okay. What type of suture material would you use, sir?
Yeah, it would be based, obviously, every suture material is based on the diameter of the tendon or a nerve. So here you would go for 8O or a 9O kind of a suture.
And how many sutures do you anticipate that you will be able to take, anterior and posterior, or number of sutures?
Probably about 4 to 5 all around.
Okay, okay. So we have taken 4 sutures. Now my question to Leena Jain, there was ulnar digital artery injury as well, along with the ulnar digital nerve. May I know whether will you consider repairing the digital artery in this case?
Article. Suppose if the article is, see, our aim is to minimize the time.
Yeah, Dr.
One
Hari sir,
is reverse
just
time,
unmute
and then
yourself for a while. Is Dr. Leena Jain around?
Yeah.
Yeah.
I'm unmuted.
Yes.
Hello.
So,
Am I
yeah.
audible?
Yes, you are audible.
No. Yeah. If there is an injury to the ulnar digital artery of the ring finger, I would repair the artery because this would ensure a better healing of the nerve repair. In the presence of ischemia, nerve repairs are always be
Okay, okay. So, Dr. Hari sir, may I know whether would you also consider repairing ulnar digital artery?
If it comes very comfortably without any graft or anything, no, then we will repair it because it is lying there and you're anyway under microscope.
Okay.
And, but yes, if it is contused and if it is not coming directly, then we will not repair it.
Okay, okay. So, so I did not repair it because the two approximation, I mean the two ends of getting approximated was very tight, and it was not difficult. I mean, it was little bit difficult to repair the artery, and I did not do it. My ulnar nerve repair site, ulnar digital repair site was very close to my tendon repair site, and I was in a fear. I had a fear of that tendon repair. The suture ends were rubbing around my nerve repair site. So what I did was I took a small fascia from the distal forearm and wrapped the nerve repair end with that fascia, just to only avoid it's getting rubbed against the tendon repair site. Sometime I have seen in my own operated case that if the tendon repair and nerve repair are at the same level, then sometimes it gives a strong Tinel sign to the patient and the mobilization becomes difficult. In this patient, I had done I had covered the ulnar digital nerve repair. I had covered with the distal forearm fascia. My question to Dr. Mukund Thatte sir, does this fat or fascia wrapping around the repaired nerve work according to you?
So, Parag, yes, this is a difficult situation you were in, but between fat and fascia, I prefer fat.
Okay, sir. Okay.
Fascia can become tight and cause compression.
Okay.
A loosely put pad of fat which is available locally is a little safer than fascia.
Okay,
Do you prefer tissue glue or sutures? I would put one suture and tissue glue. In fact, the added advantage of tissue glue is that it's like a flap.
Yes, sir.
There is a, cylinder of tissue glue around the nerve, and therefore it's not directly in contact.
Yes, sir. Yes, sir. Any tips to prevent irritation of sutures of tendon to nerve repair? I think you would use tissue glue to prevent.
If it's that close, I would put a fat flap.
Okay, sir. Okay. Thank you very much, sir. So the take-home message from here that whenever you have a zone 2 or 3 lacerations, you please suspect a digital nerve injury along with the tendon injury as well. Make sure that the repair site of digital nerve should not rub or get irritated at the repair site of the tendon, and you can consider these two salient points considering a fat or using a tissue glue, and cut sutures of the tendon very close to the repair site, or considering the nerve repair site with the fat or tissue glue, and suspect digital nerve injury to adjacent to digit as well, because many times we feel that the little finger tendon injury is cut. That means the other probably structures we need to really look for, so that we should not miss the other digital neurovascular bundle injuries to the other digit as well. I thank you very much. Thank you, Dr. Gautam sir. If there are any questions, I'm happy to answer them.
Thank you, Parag. That was a lovely presentation. I think for the general orthopedic audience, the message also was that there's a need to examine the patient for nerve and tendon injuries in any patient who has a CLW. Number two is that whenever you are exploring, the incision planning was very nice because he could explore and expose all the nerves and tendons very well, whatever he needed to within that area. So that is an extremely important job. So thank you very much. And without
Thank
much,
you, sir.
we can start your presentation.
Parag, can I make a point?
Yes, sir. Please do.
of course, you might not require ultrasound or MRI and all, but at least I would insist that an X-ray should be taken, especially in open injuries, because and it's sutured and it's come to us, because a lot of time there could be foreign bodies like
True,
glass
sir.
pieces and things, and it might not be in the line of your incision. It might have
Agree, sir.
migrated. So that is a very important thing to document and also look for it during your procedure.
Agree, sir.
Tissues you
X-rays.
would always open and see, and then you see the nerve and tendon, but sometimes glass pieces and things like that, which might be tiny, and that needs to be documented. If they're radio opaque, at least they'll be seen nicely.
Completely agree, sir. X-ray is essential in any CLWs of the hand. Thank you very much for making that point, sir. Yes, Rohan. Yeah.
Hi, good morning. Thank you, Bombay Orthopedic Society and Parag, for giving me the opportunity. I'll be speaking on nerves in hand, and the objectives would be to go through the anatomy, epidemiology, evaluation, prevention, and management. Quickly through the anatomy, the nerves of the hand. If you see here, the median nerve exits the carpal tunnel, then it gives out the recurrent motor branch. It gives out a sensory branch to the radial side of the thumb. Then you have a common digital nerve, which divides into a proper digital to the radial aspect of the index and the ulnar aspect of the thumb. Similarly, you have a second common digital nerve and a third common digital nerve. On the ulnar side, the ulnar nerve exits the Guillen's canal, gives out the deep motor branch to supply the muscles of the hand. You have a common digital nerve giving out to proper digital nerves for the ring and the little finger, and one little finger nerve to the ulnar aspect of the little finger. As you go distal, beyond the level of the distal palmar crease, the common digital divides into a proper digital to the either fingers, which further divides at the first crease of the finger into a palmar cutaneous branch and a dorsal cutaneous branch. So this is the basic anatomy of nerves in the hand. What's the surgical significance? Always remember, nerves in the hand are volar to the flexor tendon. So in case you have a flexor tendon injury on the volar side, always examine for a digital nerve injury. Remember, the nerves are parallel to the axis. So any transverse injury to the palm or the finger invariably injures the nerve, whereas a longitudinal injury the nerves may be spared. When you're dissecting the nerves during a surgery or during debridement of an injury, remember, nerves have some fat around it. So be wary of a structure with some little fat around it. A quick point on where you inject, or try not to inject at the A1 pulley because the nerves don't divide here. Try and inject in the web when you're going to anesthetize the fingers. Also, try and inject in the center of the ray, rather than in between the two rays, because you may end up injecting into the nerve. The commonest injuries are usually in the kitchen with mixie, knife, occasionally with kites. The second common injuries would be a crush injury between two heavy objects. And occasionally you do get iatrogenic injuries when we are doing surgeries. Whenever you are suspecting a digital nerve or a nerve injury in the hand, it's always important to assess them. And the most important is the sensation. And always remember, examine the sensation on either side of the finger pulp, because the sensations here and here are supplied by two different nerves. You could use a pinprick or you could use a touch sensation. Another common thing is a wrinkle test, where you keep the fingers in warm water for about 5 to 10 minutes. And the denervated area usually ends up being smooth, whereas a normal area will start showing some wrinkles. For me, the most sensitive test is a 2-point discrimination test as described in the picture. And I would do it on either side of the pulp so as to understand what part of the digital nerve is injured. TNILS is important if it's a delayed presentation, and ultrasound and MRI is primarily for a completion of the discussion. Before we go on to the management, how do you prevent these injuries, especially iatrogenic injuries? See, kitchen injuries or crush injuries are unavoidable, but the iatrogenic injuries are avoidable. So quick salient points. So if you look at your finger from the side, you see a divide between the brown skin dorsally and a white skin volarly, and that's a watershed line. So try and stay. So when you're putting an external fixator, try and stay just above the watershed line, because you might, if you're volar, you might skiv and injure the nerve as well as the neurovascular bundle. When you're doing any open reduction via the mid-lateral approach, try and stay at this or just above this. When you're doing any surgery on the volar aspect of the hand, when you're using a Brunner's incision, make sure that your first incision is just through the skin, and then you use blunt dissection. Dissection ideally should be in line with the finger. The commonest injury to the digital nerves is usually at the corners of the Brunner's incision. So be very careful when you make your first skin cut. And for me, this is where most of the digital nerve injuries will happen. When you do a trigger thumb release, the radial digital nerve is very, very superficial. And actually it's more superficial as compared to the ulnar digital nerve. This is an odd case where the ulnar digital nerve was injured. Literature says it's the radial digital nerve which is commonly injured. So when you make this incision, try and stay only at the skin and then use a blunt dissecting forceps in line with the finger. The common digital nerve will also be injured if you're using when you're doing a trigger finger release. So be sure that you are, when you're incising the A1 pulley, you are in line with the ray and not on the side. It helps when you clear out the complete soft tissue. At the wrist level, you have the superficial radial nerve that is commonly injured. Again, when you make an incision, either transverse or a straight incision, make sure that dissection is in longitudinal, and any cut that you're making is longitudinal and not transverse. Briefly about distal radius, everyone does this surgery. Everyone can see the median nerve. Everyone can see the median nerve. What people usually miss is the palmar cutaneous branch of the median nerve. And this lies right on the sheath of the FCR. So whenever you're making an incision on the FCR sheath, primarily the posterior sheath, make sure it's in the center and it's not radial, because the nerve lies radial on the FCR posterior sheath. When you're doing a carpal tunnel release, it's a simple surgery, straightforward surgery, but occasionally the recurrent motor branch, the thenar motor branch, can be injured if it's going through the ligament, the transverse carpal ligament. So before you make an incision over here, over the transverse carpal ligament, assess for any recurrent motor branch. Most of the management is quite similar as discussed by our senior faculty. Whenever you are suspecting a digital nerve, either a common digital nerve or a proper digital nerve injury, make sure you have examined the patient well, define which part of the nerve is injured. When you do the surgery, always ensure that you extend beyond the zone of the injury so that you can identify the nerve ends. You can prepare the nerve ends well. And like our senior faculty said, repair the nerve without any tensions. I would not go in details about the repair. Primarily, it's an 6-0 or an 8-0 ethylon stitch, depending upon the size of the nerve in the palm. If you're looking at the digital nerve in the fingers, it's primarily an 8-0 or a 9-0 stitch. The other things that you could use would be a glue, occasionally a conduit. I have no experience with a conduit. And if it's a significant defect, then a nerve graft is helpful. I thank Parag for this case. This is just to show that how innocuous this injury is. This is a kite injury to a young girl, which was probably missed as a simple injury and probably treated with a Band-Aid. But if you examine the distal area well, especially the ulnar pulp, she had diminished sensation. The rest of the function of the finger was okay. And when you follow the principle, when you need to open a little distal and a little proximal so as to identify the nerve ends, and use 8-0 or 9-0 to repair the nerve. I thank Bipin for this case. Again, this is a fan injury. The problem with these injuries is patients come with a lot of pain, and we may miss examining the distal sensation while we are examining tendons and vascularity. So it's always important that if you have injuries in the area of the nerve, so this area would be the common digital nerves, it's always important to document the sensation on either sides of the pulp of the finger. So in this case, you should compare sensations on the radial and ulnar side of the middle and the radial and ulnar side of the ring. In this case, we extended the incision. We found the common digital nerve to the middle and the ring finger injured, and this was well repaired. So the take-home point in the short talk is, whenever you see an injury or whenever you're doing a surgery, always know the anatomy and always have an idea of what nerve that you would encounter. Remember, a smallest of the wound, like a small 1 centimeter kite wound or even a puncture wound by a stab, can cause a nerve injury. And hence it's essential to examine the sensations distally. When you get into a situation where you're suspecting a nerve injury, it's important to document and then explore, repair, or reconstruct. Thank you so much.
Thank you, Dr. Rohan. Excellent practical tips you gave to all of us. Now, Dr. Gautam, if there are no questions from audience, I think first we will finish the presentation and then we can take a collective questions.
Just one question to you directly, and that is, can you tell us the name of the commercially available tissue glue?
Sir, there are two, sir. One is Tisil, which is manufactured by Baxter, Tisil, and one manufactured by Reliance also. So, but usually we prefer Tisil, Tisil.
Yes, thank you very much. That was a question from Dr. Sujit Jain of Mulund.
Yes, sir. So now I welcome Dr. Bipin Gangurde to share his case. Now we are moving ahead, and Bipin, yes, over to you.
Okay, thank you, Parag, for this case. So this is a very complicated case in a ICU patient whose arm was tied to the bed. So, so in general, I would like to tell you what are the physical restraints. They are basically to restrict the normal activity of the patient and physical activities. And they are normally used in most of the hospitals during critical care and range of difficult clinical scenarios. And they are intended to protect the patients. However, a similar type of patient presented to us with he was a 20-year-old man with a left wrist drop, inability to flex the wrist, inability to move the fingers, elbow flexion and extension was present. There was patchy sensory loss more on the median and on the ulnar nerve area. However, there was a significant tenal sign positive at the mid-arm level. So past history, as I told you, this patient had head injury 2 months back. He was in ICU for 2 months back. And his arm was tied to the bed to restrain him from violent movement. Post consciousness, the patient noticed that there was paralysis of the left hand. Injection methylprednisolone was given in the ICU. However, there was no recovery and the patient was eventually discharged. So my question to Dr. Anil Bhatt sir and Hemant Patankar sir, what is anything specific in clinical examination would you like to know in this patient?
Bipin, can you make a video? Is there a video of this patient?
Yes. So this is the video of the patient. So Anil Bhatt sir, would you like to know anything more in this patient? Hello.
At what level was it restrained? As in at
This
the
was
wrist?
at the mid-arm level.
Mid-arm level.
Yeah. See, actually, the patient presented to us with the paralysis itself. Patient told us this that it was there something was tied to his mid-arm level. Clinically, the tenals was significantly static tenals at the mid-arm level. That is the only clinical finding which clinically I got, and this video. Now, how would you go about knowing anything? Like, how will you distinguish it from a brachial plexus injuries? Because this patient was also accompanied with a EMG NCV report, which said that it was a brachial plexus injury. And further, one report which comes as brachial plexus, always it remains as brachial plexus.
Correct.
So it was like that. So clinically, what you would like to know to rule out if this is a brachial plexus injury or anything else you want to tell us?
Of course, the clinical examination itself, right from going from distal to proximal, seeing what components are involved, which of the nerves are involved, is it matching the basic components of the nerves? So is it matching the upper brachial plexus or a lower brachial plexus or a global kind of a thing? So that should match. If there's a mismatch, there's always a problem that it could be some localized kind of an injury. Second thing is pain could be a very major component of these injuries. So it's generally brachial plexus patients don't come with sort of a lot of pain, but here pain could be a major kind of a component or patient presentation here. So third, of course, would be the local examination itself at the area where he would tell you what has happened. So you would look for telltale signs of local constriction and damage to the skin and the surrounding tissues. So all these put together, probably you can arrive at a diagnosis whether it is brachial plexus or is it a localized kind of a constriction leading to this. And then what nerves are involved if it is so. So it should, if the pattern is not followed in terms of a brachial plexus kind of a lesion, then definitely you need to start thinking what else has happened. Is it a localized kind of a problem related to the physical restrict?
Okay, thank you. Patankar sir, anything else you would like to add? Hello? Okay. So basically, I would like to make a note here that the shoulder and the deltoid function was working as Dr. Anil Bhatti had shown in his talk, that how he checks the deltoid. So we did not classify it as a brachial plexus injury clinically. Now we go ahead further with Mukund Thatte sir. You're there, sir? Hello.
Yes, I'm there.
Sir, any investigations? You saw the case?
Yes, I saw the case.
Any investigation specific, MRI, EMG, NCV, USG, or any other investigation would you like to?
So you did a EMG, NCV, you said, which led to brachial plexus.
No, the patient came with a EMG, NCV, which said that it was a brachial
I would
plexus.
see the quality of the EMG, NCV and then decide whether to trust it or not.
Okay.
And second, I would always then do an MRI, because our study has shown that a combination of MRI and electrophysiology is very unlikely to miss a brachial plexus. If the MRI also shows brachial plexus injury and electrophysiology also shows brachial plexus injury, then I would definitely think of brachial plexus. Definitely, I would do an ultrasonography of this mid-arm. The one issue I have, Bipin, is typically these rowdy patients are not restrained at mid-arm level. They are either restrained at the wrist level or the axilla level. So mid-arm is a very unusual place to restrain the patient. And if he has been so badly restrained that you have a triple nerve palsy, like you are saying, then there would be marks on the mid-arm, which would be pretty specific to that restraint. So did you look for those marks?
Yeah. So the patient came 2 months after this thing happened.
Even then you will see marks.
So there were no significant markings, sir, which present.
And did you have any relatives with him to whom you could ask where he was restrained?
So everyone, so relatives, and the history they gave was that he was restrained at that level like this. He was tied to the
So the other last point I wanted to make, if he is restrained in a hyperabduction, it again goes in favor of a lower trunk injury.
Okay. So, but sir, with the clinical examination, which we have done before, deltoid and the upper shoulder muscles are okay. Would you still go for MRI of the brachial plexus?
Yes, definitely, because so it really depends on the electrophysiology quality. If the electrophysiology is showing that yes, there is an injury at the brachial plexus level and not at the lower level, then yes, I would do a MRI.
So first you would do a electrodiagnostic study, and then follow it with whatever you want to do.
Within your case is very peculiar. It is a triple nerve injury, which would look like a tourniquet palsy also, sort of.
Yeah.
But in your case, there is a clear history of hyperabduction and restraint. Hyperabduction causes injury to the lower trunk, not the upper and middle. And therefore, if brachial plexus injury is possible.
So very high quality EMG NCV was done by me again, by us basically again after the quality of the EMG NCV, as you said, was told as brachial plexus injury. Only the diagnosis was brachial plexus injury. So these are the results of the high quality brachial plexus, sorry, the EMG NCV. So what would you like to know now in this, like which level would you comment is the injury, or would you go for an MRI more?
I would do an MRI just to be sure, because I don't want to open all over the place on table. I would do a pre-op MRI. I would also do a very good quality ultrasound.
Okay, so you would do a MRI.
Ultrasound would show me altered structure of the fascicular pattern in the mid-arm level, if that is where the injury is.
Okay, so you would do a MRI and an ultrasound.
Yes.
Okay, sir. Hari sir, you're there, Hari sir?
No,
Hari
Dr.
sir?
Hari, no, he is not here.
Acha, so Patankar sir is there? But sir? Anil Bhatt sir?
Well, another point is even with the restraint, it's not a kind of static kind of a force. Head injury patients are always restless. So we really don't know exactly what is the mechanism. Is it like just a static kind of a injury there, or there was an associated traction injury? So as sir was telling, I think it's wise to go and check preoperatively with an MRI and see where the injuries are, and also document with the ultrasound, because your electrophysiology again might not really correlate with your physical findings. So it's more of a dynamic nature. When patient is restless, moving around, somebody is holding him and restraining him, all sorts of injuries could have happened. So we are not sure exactly the mechanism of injury in this. And of course, the component of injury at the time of accident itself.
Okay, so you both want to do an MRI with an EMG NCV,
which I did. And a sonography, Bipin.
Which I did not do. So I went ahead and decided to, what would you do? Like if you would wait or you would explore at that point of time. 2 months is the time.
I would explore. With a triple nerve palsy, 2 months is good enough.
But sir, what is your idea on this?
Definitely. Earlier the better.
So both of you would explore. Anyone who doesn't want to explore?
He is leading us down a trap, Anil.
Hello.
I know, sir. I want to go into the trap so that we'll pull him later into that.
Amit Vyas? Amit Vyas?
Yeah.
Okay, Bipin, go ahead now.
Yeah, explore करेंगे या wait करेंगे 2 महीने? What would you do?
It is already 3 months.
2 months. 2 months.
2 months.
जल्दी बोलो, अमित, टाइम नहीं है. चलो,
he is waiting to explore. So both he's doing.
Nobody will give you marks for negative marking. बोलना है बोल दे. Anyway, go ahead. We are running out of time. Bipin, what did you do?
So we waited. So I waited for, and Parag were there in this case. So waited. How much will you wait again, sir? Satyam sir, you will not wait. Patankar sir is there. I think he will be with me. He will wait. Patankar sir?
No, I have a question for Dr. Bhatt. Dr. Bhatt, when you say exploration, what will you explore and where will you explore? I mean, this is not a place where there has been an open injury or anything that you can explore, and what will you see?
Yeah, I mean, that would definitely, as sir was telling, it depends on your MRI findings and your ultrasound findings. So if it is nothing conclusive from both of these, I would wait as Bipin has told. Otherwise, if you see a specific injury happening there, I think it should be explored. So it all depends on what we see on the MRI and ultrasound, and that gives you additional information for the decision making there.
Correct.
Gautam, can I interject?
Yes.
Unless you do all three, you are not coming to a diagnosis. And without a diagnosis, you can't do the treatment.
Yes, I agree, sir. Bipin, the basic principle, what the seniors are telling you is that in a case where your clinical findings and your other findings don't match, you must try and obtain as much information as possible before making a decision. So this is a difficult case. Symptoms, signs are not matching, story is not matching, in which case I think getting all the investigations possible would be nice. But anyway, you waited. So tell us after how much long the patient started recovering.
Okay, so 4 months. Now still no recovery. Wait, new EMG NCV or explore? So this is a very dicey situation again. So as Tatya sir and Bhatt sir has already told that they would not wait, and there was no so there was no backup MRI and no sonography. And clinically, we felt that it was a mid-arm injury. It was totally clinically, we felt that it was a mid-arm injury because the shoulder muscles were good. And so we decided to explore. So Anil Bhatia sir is there. So if it is a mid-arm injury, like due to the restraint in the mid-arm, so how would you explore this? Anil Bhatia sir is there. Okay, Leena is there. Dr. Leena.
I think you move ahead and show what you did because we have run out of time now completely.
Okay, so we explored medial approach and dorsal approach. In the medial approach, musculocutaneous nerve, median nerve was seen. Interfascicular dissection of the median nerve was done. There was fibrosis around this nerve, a lot of fibrosis. No neuromass, multiple neuromass seen. Again, the ulnar nerve, there was fibrosis around the ulnar nerve. So this was done under high dissection microscope. So this was in the medial approach, and dorsal approach, as we take for the humerus, we did the neurolysis of the radial nerve. So this was what we did at 4 months. So this patient is now at 2 months follow-up post, and he is recovering function. The radial nerve is coming up. The median and ulnar nerve is coming up. We are still waiting for the follow-up. So what I found in the literature is that palsy due to nerve compression heals within 3 to 6 months. That is for the by Sunderland in 1968. Only these are like old. Another case was in 1945, which was reported of very bad tourniquet paralysis. Now this is very different from the restraint which we are giving. But olden day times, they used to use the edge mark or some rubber tubing to be tied around the arm. So in this case, he found that the diameter of the nerve was reduced, and there was scarring and neuroma which were found, which we found in our case also. So this is my conclusion, but I would like to differ again on this conclusion with Dr. Thatte and Dr. Bhatt in picture. Like, we would like to add another investigation with this confusing clinical scenario of MRI and sonography to rule out any other nerve lesion or a higher brachial plexus injury, even though clinically we are sure that it is not a brachial plexus injury. Explore immediately is what Satya sir and Bhatt sir have told us. We explored at 4 months as there was no sign of recovery clinically and on radio electrodiagnosis. After exploration and even after any tourniquet or pulses, the sensory disturbance which remains for a longer time, which will eventually recover, but it takes a long time. Thank you.
Thank you, Dr. Bipin. I think we will move on with the presentation of Dr. Leena Jain for tourniquet palsy. Bipin, can you please stop sharing your screen?
Yeah.
Yeah. Dr. Leena, please start your screen.
Yeah, sure. Hello, a very good afternoon to all. Bipin, thank you for the case. Now, the highlight of the talk is going to be on essentials of safe use of a tourniquet. A tourniquet is a constricting or a compressing device used to control venous and arterial circulation to an extremity for a given period of time. The term was coined by Louis Petit, who used the term turner, which means to turn. And Cushing devised the first pneumatic tourniquet as early as 1904. Now we, of course, have electronic tourniquets as devised by McEwan. Now, to highlight about the types of tourniquet, we have non-inflatable tourniquet, pneumatic tourniquet, electronic tourniquet, and disposable tourniquet. Now, the problem with disposable tourniquet is that the width of the proximal part of the cuff, which is the pressure-bearing area, is very narrow. Hence, there's a high degree of pressure applied to a very narrow bridge of the cuff, causing undue pressure over a very small surface area. Second is the pressure is calibrated for particular tourniquets, which may not be specific to a particular limb or to a particular patient. So in a way, I'm not sure if they should really be used. Pneumatic tourniquets or electronic tourniquets can be specifically used for a particular patient and particular limb, and they may be much more safer. Now, Bruno has described 10 golden rules on safe tourniquet use, and I just like to highlight that for the audience because it's essential for all of us to know. Firstly, it's very important for the operating surgeon himself or herself to apply the tourniquet. Now, how do you select a cuff? First is where you're going to apply the cuff, what is going to be the shape of the cuff, and how long the cuff needs to be. Cuff needs to be applied at the maximum circumference of the limb, either the upper or the lower extremity. The shape of the cuff, what we use normally is a rectangular cuff, but you have contoured cuffs which have a smaller diameter distally and a wider diameter proximally. The advantage of contoured cuffs, so if you look at the arm, a lot of people would have a wider upper arm, wider narrower lower arm. So a contoured cuff would fit very snugly and provide a uniform pressure across the width of the cuff versus a rectangular cuff. Besides that, the contoured cuff would not slip away easily, while a rectangular cuff, there would be chance of slipping away. Now, the cuff length needs to be, there should be an overlap of at least 3 inches and a maximum of 6 inches. A greater overlap will result in a greater pressure because of 2 layers of overlap. Next is how wide the cuff needs to be. Now, width of the cuff is actually a very important parameter apart from the limb occlusion pressure. The cuff width needs to be at least as wide as half the limb circumference. Wider the cuff, lesser would be per square unit pressure applied to the underlying area. Limb protection beneath the cuff is important in the form of limb protection sleeve or 2 layers of gamgee roll. How do you determine the cuff pressure? Now, cuff pressure determinants are systolic blood pressure, the specifications of the cuff, limb circumference, and vascular status. There's something called limb occlusion pressure, which is a little different from the systolic blood pressure. Now, limb occlusion pressure is the minimum pressure required at a specific time in a specific tourniquet cuff applied to a specific patient's limb at a specific location to stop arterial inflow. The limb occlusion pressure needs to be checked after induction of anesthesia once the antibiotic dose is gone. The cuff pressure will be limb occlusion pressure plus safety margin. Now, how does one determine the limb occlusion pressure? Once the tourniquet cuff is tight, you can use a handheld Doppler or a ultrasound Doppler. If an ultrasound has been used for a brachial plexus block, then the Doppler can be used to raise the pressure in the cuff and see at what point the arterial blood flow is stopping. Or one can also connect the cuff tubing to a sphygmomanometer, raise the systolic blood pressure and see at what point the arterial inflow is stopping. Now, the cuff pressure is calculated by a safety margin. Safety margin is important to overcome the intraoperative variability of the systolic blood pressure. So the safety margin varies depending on the limb occlusion pressure. For a limb occlusion pressure of less than 130, a safety margin of 40 is added. For a LOP of 131 to 190, a safety margin of 60 is added. And for a LOP of more than 190, a safety margin of 80 is added. For pediatric, the lip occlusion pressure plus 50 is considered to be an ideal cuff pressure. Now, tourniquet time is the second important point in preventing complications of use of tourniquet. Now, inflation time for upper extremity generally would be 60 minutes, lower extremity would be 90 minutes. For pediatric, not more than 75 minutes in the lower limb. Reperfusion time, if the tourniquet needs to be used for a longer time, then 15 minutes of deflation is required after every 1 hour of inflation. Intraoperatively, one needs to monitor the blood pressure, the tourniquet pressure, and the tourniquet time. There are really no absolute contraindications to the use of tourniquet except for probably a recent vascular repair or AV fistula, but there are contraindications for exsanguination. I'm just highlighting this point because a lot of us are confused as to use exsanguination to decongest the limb or not. That absolutely exsanguination is contraindicated in the presence of tumor, infection, and trauma. Trauma because in the presence of orthopedic trauma, an exsanguination can cause release of emboli, which can cause systemic problems. Elevation would be a good way to reduce the venous inflow. Now, the myoneural complications seen with prolonged use or excessive pressure in a tourniquet are post-tourniquet syndrome, tourniquet paralysis syndrome, and compartment syndrome. The highlight of the talk will now be a tourniquet paralysis syndrome. The tourniquet paralysis syndrome is caused by 2 important factors: mechanical compression and nerve ischemia. These together cause microvascular congestion, inadequate perfusion, and axonal degeneration. Which is more important is really not been identified, but both are extremely important contributing factors. Now, this tourniquet palsy varies from transient loss of function to irreversible paralysis, but the good part is the incidence of irreversible paralysis is as low as 0.01 to 0.13%. So now, like I mentioned, cuff width is extremely important because it helps in a uniform distribution of pressure over a wider area of surface. So 5 centimeter cuff width would ensure just a 50 mm of Ag of pressure per centimeter, while a narrower cuff would cause undue pressure over a very small surface area. Now, the primary lesion under microscope caused by compression and nerve ischemia, the large myelinated nerve fibers are what are involved first, and they cause a displacement of the node of Ranvier. They cause stretching of the paranodal myelin on one side and invagination of the paranodal myelin on the other side. So these are the effects of compression seen over the nerve segment. The etiology is, like mentioned before, high inflation pressures or a higher pressure gradient across the nerve under the tourniquet. Long duration of inflation of the cuff. One also needs to remember tourniquet palsy has been reported in cases with normal cuff pressure and normal duration of inflation. Particular patients are also at risk of tourniquet palsy, like elderly patients with calcification of major arteries, patients with rheumatoid arthritis who can have steroid-induced vascular calcification, and prolonged clotting time. Motor and sensory the upper limb is radial nerve, most common in the lower limb is common peroneal nerve. They cause considerable disability to the patient, psychological stress to the surgeon and the patient. The constellation of symptoms which constitute the tourniquet palsy syndrome are: in motor, there's paralysis with hypotonia, atonia, may not be an absolute appreciable atrophy. Sensory, almost all sensations are lost. There is no paresthesia or tingling. This is quite characteristic because the touch fibers are completely gone. Pain is present. In fact, some areas hyperalgesia has also been seen. Heat and cold sensations are usually not affected. Sympathetic fibers are not affected. Pilomotor reflex is normal. Temperature of the skin is normal. Skin resistance and color of the limb are normal. Electrophysiological studies show a complete lack of stimulation of the motor nerve above the injury, and a good response is seen on stimulation below the injury. Nerve fibers, there's no tingling distal to the site of injury, but tingling sensation can be elicited when stimulated proximal to the site of injury. Now, signs of regeneration are seen on electrophysiology at about a 3rd month, but sometimes the start of regeneration can be delayed as long as 5th month also. Now, this is one of the papers which have extensively studied on what the pattern of recovery is. So initially in the first 30 days, there's just no recovery, but from about 40 days to 100 days is when gradually the various sensations start recovering. On the extreme right are sympathetic second pain and warmth and cold, which are usually not affected in a tourniquet palsy. So about management of tourniquet palsy, like in Bipin's case, to even come to conclusion, it can be very, very confusing, especially because you've not seen the patient primarily. But with tourniquet palsy, once diagnosed or once you have a high suspicion of tourniquet palsy, spontaneous recovery is the rule. The recovery starts about 40 days later, and on ENMG, signs of degeneration can be seen at around 3 months. However, because delay has been seen for start of regeneration as up to 5 months, one needs to wait. Splinting, meanwhile, is important. Passive full range of motion is important. Irreversible palsy is seen in 0.01 to 0.13, for whom a tendon transfer or free function muscle transfer may be required depending on the segments involved. Now, to conclude, Brunner's 10 rules of safe tourniquet usage are really important, and one needs to remember every time a tourniquet has been applied. Intraoperative monitoring of the pressure and the time are important. Differential diagnosis of the spectrum of tourniquet-induced nerve complications are a compartment syndrome and a post-tourniquet syndrome. So post-tourniquet syndrome is just plain edema of the limb, which is because of post-ischemic reperfusion and hyperemia. So this causes significant edema, which can remain for quite a few days. However, there is no motor or sensory dysfunctions associated with post-tourniquet syndrome. In compartment syndrome, certain people may be prone for developing compartment syndrome, or if it's or when one applies a slab or a cast before deflation of tourniquet, those patients are more prone to develop a compartment syndrome. Now, in compartment syndrome, apart from edema, pain on passive stretch is a characteristic finding to differentiate it from a post-tourniquet paralysis. ENMG done at 3 months, if it's not showing any signs of recovery, needs to be repeated at 6 months and then evaluated. Reassurance, splinting, and serial follow-up are important. Thank you. I'd be happy to take any questions.
Yeah, thank you, Dr. Leena. Thank you. It was a very nice talk. May I ask you only one question? Like, do you prefer a calibrated tourniquet only, or nowadays we have a ring tourniquet, which they like a brand name I would like to use is called HemaClear. If you have any experience with that, they don't. I mean, they're color wise and the mid arm circumference wise, they have already calibrated such tourniquets.
Yeah. So, are you talking about like disposable tourniquet? Because we have
Disposable tourniquet.
pre-calibrated, yeah,
Yes,
and
sir.
they are ring form. But if you have noticed, the actual ring where the pressure is applied is really narrow compared to a pneumatic tourniquet, which has a very wide cuff. So at least 4 inches you would use for the upper limb and 6 inches you would use for the thigh. The problem with this disposable tourniquet, though, I'm sure it's been calibrated studying normal people, but it's not yet specific for a particular limb and a particular patient that you're using. So I would be wary to use it, really, and still prefer a pneumatic tourniquet.
Thank you. Dr. Gautam Sir, should we go ahead?
This is from the audience for Lina.
Yes,
Lina, what is the, if suppose 4 months, 5 months down the line, you said you can wait, and suppose even 6 months down the line, if the patient does not recover, is there a role for surgical neurolysis in these patients? And does it really help that neurolysis?
Surgical neurolysis at 6 months, if there's absolutely no sign of recovery, then one needs to go in and look at the nerve fibers. If there is some amount of fibrosis, then external or internal neurolysis may be indicated. At the same time, at that point in time, it would be difficult to plan a tendon transfer, especially if all the 3 nerves are involved. And it would be still early to go in for a free functional muscle transfer. So after having done a neurolysis, it may be still worthwhile to wait for some time and reassure the patients meanwhile.
Right. This is out of the talk, but being a plastic surgeon, you should be able to answer this. If there is a partial nerve injury, should we cut the nerve completely and freshen and repair, or repair the partially cut ends?
So if it's an acute injury and partially cut, then and the edges are neat, then I don't see a reason to completely cut the nerve and repair. I would cut the segment which is divided under microscope.
Okay, and your this thing on neuromine continuity, what is the management?
So for a neuroma continuity, you again under magnification, you excise the neuroma completely and you see the percentage of fibers which are intact. Once you do an internal neurolysis, you excise the neuroma and you see the percentage of continuous fibers present. If the percentage is very less, then you excise completely and you put a nerve graft or repair primarily depending on the length of the neuroma.
Right. Okay, thank you. Rohan, are you there, Rohan? Dr. Rohan Habbu? No, all right. I think then in that case, thank you, Lina, and we should move forward with the next case, Parag.
Yeah, I welcome Dr. Thatte sir to give a talk on rehabilitation outcomes and management of nerve injury.
Thank you. Hopefully the net behaves better this time. So this is again rehabilitation and long-term management after the repair. I could not show you these two earlier, so I'm showing them now. So this is a Somsax repair. I have put one suture and now I'm putting the glue. Then I wait between 90 seconds to 2 minutes. And once I remove the glue, the sheath around it, I have a lovely strong glue cylinder around the nerve and I'm quite happy about the way things are going. So this is what I do. This was part of the previous lecture. Now we'll come to the, once again, instructions from Parag. These are the instructions. So I have tried to address each one of these instructions in my talk. Relevant investigation to judge recovery. Clinically, Tinel's sign progression. Squeeze pain on muscle. People may not know about this, but a muscle which has begun re-innervating shows squeeze pain. That means if you squeeze the muscle, the patient complains of pain. Sometimes you start getting palpable contraction, even though it may not be MRC3. Electrophysiology, of course, will show you a newly re-innervating muscle. I don't know what I don't know what I have written here. So the post-op protocol of rehabilitation after nerve surgery. Consider the facts. Number one, we have operated. We found a nerve ruptured or cut or diseased. We therefore created freshened ends. We then repaired them end to end or with nerve graft. I think everybody is with me so far. What is the danger? Why do we have a protocol at all? The danger is rupture of the repair or an inadequate repair because it partially pulls out. The problem is the sutures are very fine and therefore very weak. And therefore any stress on that repair will rupture that repair. Or if the position is inappropriate. For example, if the repair is done in an abnormal flexion or extension, then any movement will rupture it. My solution is this: I repair in neutral position ideally, or at the most 5 to 10 degrees flexion for fingers and wrists. I know Hari said up to 30, but I have less courage than that. If that does not allow end-to-end repair, then I use grafts. For elbow, up to 30 to 40 degree flexion is okay, but not more. Always check the stress on table by moving under vision while open to see whether the repair is coming under undue stress. If the stress is looking inappropriate on table, then shift to graft. And always splint the repair for 3 to 6 weeks in optimum position. Why splint? Because of basic collagen biology. 3 weeks is the first peak of collagen strength and 6 weeks is the second. After that, there is a slow increase for up to a year. Between 3 and 6 weeks, the splint angle can be judiciously modified and increased. Only operating surgeon can make this call because only he or she knows what kind of stress is there and what kind they have observed intraoperative. Importance of nerve and muscle stimulation. Do I give electrical stimulation? Yes. Do I believe it helps? I don't know. Evidence is patchy. It is known that it works if given for longer period, not a typical 5 minutes a day in a busy physical therapy department, which is what happens to majority of Indian patients. It is also known that it works better as nerve stimulation at the repair site progressing distally, not really muscle stimulation. I am not sure if muscle stimulation in short bursts prevents wasting. I think it doesn't. Papers have shown that if wasting is really to be prevented, you need 4 to 8 hours of stimulation of that muscle, which is practically not possible. How long to wait for result after nerve surgery? It's a combination of nerve biology and anatomy. Nerves grow 1 millimeter a day. Calculate the distance to the target muscle. Add 3 weeks for Wallerian degeneration. Add 1 month before innervation converts to palpable contractions. I will give you a concrete example. Median nerve in mid-arm of an adult. Distance to common flexor mass is 20 centimeters, that is 200 millimeters. Add 21 days for Wallerian degeneration. Add 30 more days for the re-innervation to convert to contraction. And the earliest long flexor action, therefore, is 251 days. That is between 8 and 9 months. In this example, the APB may never reach in time. So that thing about EMG in the earlier slide that got typed there by mistake. In a case like this, I would not do a electrophysiology before 9 months because I don't expect anything before 9 months. Medical therapy, I give prednisolone after food, starting with 20 milligram OD and tapering to 5 milligram OD. I give it under cover of pantoprazole or ranitidine on empty stomach. Both are given early morning. So the pantoprazole or ranitidine is given at 6 a.m., a cup of tea with biscuit at 6:15, and the prednisolone at 6:30. This is hopefully to coincide with the body's own peak of steroids. This is started at 4 weeks post-surgery. The benefits are it reduces perineural scarring, and it is also known to help remyelination. The other therapy I give is nandrolone, 25 milligram intramuscular, 3 to 4 doses at 3 weeks intervals, again starting 4 weeks after surgery. It is considered useful in improving nerve regeneration. I want to give a public caution here Both these uses are off-label as far as manufacturers are concerned. The treating doctor needs to take responsibility and to check for problematic comorbidities. For example, kidney disease is a contraindication. Or a strong diabetes, then you need to closely collaborate with the diabetic specialist of the patient because your steroid will push up the sugar levels, so on and so forth. Tacrolimus, which I have not included in the slide here, which is given after kidney transplant as an immunosuppressant, has a known effect for improving nerve regeneration in very low doses, in fact, non-immunosuppressant doses. However, once again, off-label, and I have not yet had the courage to use tacrolimus. What if repair fails? The options are re-repair or distal transfer of a nerve if it is still in the physiological time limits like we discussed earlier. For example, nerve to PQ to ulnar nerve for a high ulnar nerve injury. If nerve surgery is not feasible, then there are only two remaining options: tendon transfer, if available donors are present, or a free functioning muscle transfer. Two examples: a claw correction in a high ulnar or opponent's plasty in a high median by the use of tendons, or a gracilis for elbow in a failed brachial plexus repair. I thank you for your attention. I am happy to take questions.
I would like to welcome any of the panelists to ask questions to Dr. Thatte on this topic.
Gautam, I hoped I answered some of the questions you had raised earlier.
Yes, sir. All of them were answered. Thank you very much. That is precisely what I wanted out of the lecture. Very clear how you deal with it is for us. So that was very important. Any questions from the audience? I have not yet got any questions, but from the other
audience is exhausted.
Those keenly listening, and in fact, they are the ones who have been asking us questions all along. So they are not exhausted, but I think whatever questions they had, you have clearly answered them. Bipin, you have something for?
Sir,
can I ask one question?
Hello, sir.
Yeah.
Sir?
Yeah.
Sir, how much? What is the duration of time you would immobilize a patient in after repairing a nerve?
3 weeks minimum. It depends on which nerve. 3 weeks minimum.
You will not mobilize it at all.
No. So, for example, Bipin, if I have done a median nerve in the forearm,
yes,
I will give a below elbow slab. I will leave fingers free. I will mobilize all the fingers. I will mobilize elbow, but I will not let the wrist move.
For 3 weeks.
Because the wrist motion will definitely impinge on the median nerve. Okay. So I will test that on table after repairing. On table, I will move the elbow. I will move the fingers. I will move the wrist. I will see what is moving the nerve, and I will splint that joint.
Okay. Thank you,
Sir, I want to ask one question.
Yeah.
In which cases of nerve repair, you will do primarily distal transfer along with the nerve repair or grafting?
So a very high ulnar or median, where I don't expect intrinsics to come back, then if I have a suitable donor, I will do a distal transfer. For example, in a very high ulnar, I will do nerve to PQ to ulnar at the same time as doing the main ulnar.
Okay. Thank you, sir.
Is the prednisolone routine for all patients?
I give it to all patients, unless there is a specific contraindication.
Right. I think that's
Thank
great.
you.
Do you follow that?
I'd like to move on and invite our coordinator for today's program, Dr. Parag Lad, to end the session with talking about a common, not an uncommon orthopedic problem, what we in the good old days used to call as reflex sympathetic dystrophy. It has a very fancy name now called complex regional pain syndrome. And Parag has done some original research work on this topic, and so would be the right person to speak on this. So Parag, please take over.
Yeah, thank you, Dr. Gautam sir. And I am very sure that once we see such patients, and if we have treated them, and if the patient lands up in CRPS, we really feel very, these patients, they take a lot of time in our OPD. And so far, these many terminologies are already proved for CRPS. And I know it was a short note in orthopedic theory examination, but it's a long question in clinical practice. it is definitely very difficult to treat such condition. And I'm not going to go in detail, but then I must explain you why does it happen. So there are 5 things where there is an injury stimulus to the skin, either from the trauma or fracture or because of burns or any injury to the skin, and that releases the trigger response, which in further consequence it activates the sympathetic chain, and that sympathetic chain gives changes in the skin and bone. So when there is an injury to the skin, and that if we don't follow the precaution of elevation or hand elevation or mobilization, then the hand becomes red, or we see changes in the bone in the form of osteopenia. There is simple classification to follow. CRPS 1, it means no nerve injury. It is called reflex sympathetic dystrophy. And CRPS 2, it is always due to nerve injury, and it is called causalgia. And the clinical features of these two are CRPS 1 are usually trauma related or caste related issues. And commonest clinical features are spontaneous pain, different skin temperature, and hyperalgesia. X-ray picture usually shows osteopenia, which I will show you. And in CRPS2, usually they are missed or injuries to the cutaneous nerve during the surgery. The commonest surgery that performed is distal radius fracture fixation with K wiring, or ulnar styloid fracture fixation with K wiring. And usually as the nerve is involved, the clinical features produced are of nerve involvement, burning pain, allodynia, hyperalgesia, and usually we do not see any X-ray changes. The etiology of CRPS is poor compliance in following simple instruction of hand elevation or doing range of movement exercises in following etiologies. Many times we see we see this in upper limb fractures or a soft tissue trauma after the surgery, soft tissue or bony. Sometimes we have seen CRPS in IV extravasation, and sometimes we have seen CRPS in after burns or tendinopathies like simple D-curvan stenosynovitis. If it is not treated in time, they produce CRPS. That is CRPS type 1. Does it really need any investigation? Diagnosis of CRPS2 is definitely mainly clinical, but in CRPS1, when there is no nerve injury, and if the cause is non-traumatic, then just a simple redness of the hand, hyperalgesia, and difficulty in movement, we need to confirm whether it is a cellulitis or a CRPS. And what does literature say about it is X-rays in CRPS1 have around 57 to 94% specificity, but bone scan is 100% specific to diagnose this. I have used a bone scan only in one condition, I mean one of my patient, but I have never investigated patients by doing MRI. What we see in the scan is spotted bone marrow edema in the carpal region, skin edema, and joint effusion, and there could be intra-articular uptake. Let us take an example like this lady who had now presented to us 6 weeks post ulnar fracture, which was treated in a cast. Left hand was affected, the right hand movement was adequate, and she was unable to move the left hand as well as the wrist, and the simple innocuous looking fracture. So this is the classic X-ray of CRPS. You see generalized osteopenia, united, malunited, or non-union of the fracture. So this is classical diagnosis of CRPS on X-ray. How do we prevent and manage? The ideal way to do is we need to identify the psychology of the patient before we definitely intervene. Many patients on their face, and like patient who has a distal radius fracture, their pain threshold or pain bearing capacity, we can judge how early mobilization we should start for these patients and how they can land up in a CRPS. From our point of view, whenever we are operating such cases, if we are doing a K-wire fixation, avoid multiple attempts of putting K-wire. Use CM and use proper anatomical landmarks, and your soft tissue handling of surgery should be very adequate. And if the CRPS has happened with us, we should not refer them immediately to physiotherapists. We have to diagnose and we have to manage till it is cured. So I have now taken some of the examples. Now, this is the commonest X-ray we see in our clinical practice, extra-articular distal radius fracture. And look at the way in which the cast was given. The MCP crease of the thumb is not free. In the MCP crease of the metacarpophalangeal joint is not free. The plaster has been extended till the elbow. So such patients are very likely they will not have the very adequate pain-free recovery post cast removal. So the message here I would like to give is we should have a proper cast given, like is shown here. The distal palmar crease should be visible. Patient should be able to do full extension and full flexion of the fingers, and his thumb movements should be free. And remember, even if you are given a cast, advise them to move shoulder and elbow on day 1. Now, if we talk about CRPS2, which are related to nerve injuries, let us take one example. Commonest fracture fixation that we do is multiple K wiring for distal radius fracture. And if the patient is not comfortable using his hand after pinning, he is definitely going to get a high chance of CRPS. And if we want to avoid this, we must avoid putting multiple K wires in this fashion, because the excursion of the extensor tendon or a flexor tendon, if it is not free, such patients are likely to have CRPS in future. So this is the way we should put a K wire, and whenever you are passing a K wire, do not hesitate to take a small incision, and please, once you put the K wire, please try to move the skin. Please check the excursion of the skin around the K wire, and if it is not free, then at least make a small incision and then excursion should be made free. The third case that I want to show is this patient who had a distal radius fracture with the DRUJ injury, and the TFCC was repaired with the suture anchor, and the transverse K wire was put for stabilization of DRUJ, and that K wire went through dorsal cutaneous branch of the ulnar nerve, and that's why this patient had continuous burning sensation and very painful period post-op. And the moment we removed the K wire, the patient improved. This case, which Dr. Bhatia touched in the morning, sorry, post distal radius plating, this patient had persistent pain in the palmar aspect of the hand. Surgeon thought that the plate is causing irritation to the flexor tendon, and that's why he removed the implant after the fracture healing. But even after the implant removal, he had persistent pain in the palm and sensory deficit and persistent pain at the operative site. Look at, this was the operative site, and there was a neuroma of the palmar cutaneous branch of the median nerve, which has a origin 5 to 7 centimeter proximal to the wrist crease. And if we don't treat this neuroma, the patient is not going to develop, or patient is not going to have recovery from the CRPS2. And this patient was undergone a sural nerve grafting after excision of the neuroma. So the message here I would like to give: in distal radius fracture fixation, be on the flexor carpi radialis. If you do not want to fix the ulnar side of the fracture fragment, then be on the radial side, be on the FCR sheath. Then you can avoid injury to the palmar cutaneous branch of median nerve. The treatment algorithm I follow, that first of all, diagnose whether it is CRPS 1 or 2. CRPS 2, treat the cause. Don't refer the patient to physiotherapy, because here the nerve is iatrogenically, or at the time of injury it has been damaged, and then we have to repair as per the nerve repair protocol that we are listening since morning. So such patient you can operate during active CRPS phase also, because their problem will not be solved unless you treat the nerve injury. Now, when we treat the CRPS 1, I personally feel reassure the patient that you will not, because these patients are in search of a doctor who can understand them and treat them, because many times we send them to therapists, and then that is the problem. I usually try to find out how safe I am to give analgesics and NSAIDs to this patient. So rule out these two problems, and you have to go through multiple files and understand what medications the patient has consumed so far, because many times the moment you write Voveron sheet, the patient always tells that I always take it. The moment you write Ultraset, she will say iske liye bina to main soungi nahi. So this problem, I mean, we have to understand what analgesics has not been given to him so far, and we need to have very frequent follow-up. Now, what medical management, the choice of analgesic that I prefer is naproxen, COX-2 inhibitor, acetaminophen, that is Lanol ER, and tapentadol. Recently, we just had a journal club through BOS. I prefer gabapentin 300 milligram, and that works only for 2 weeks. Beyond 2 weeks, it starts giving side effect of dizziness, somnolence, or sleeping disturbance. Vitamin C, Usually we prescribe 3 times in a day for 2 weeks, and I also prescribe transdermal patches. My first aim in first 2 weeks is to have complete pain relief, because unless there is a pain relief, such patients are not going to start any therapy. And trypsin chymotrypsin combination twice a day also works here. And the mobilization protocol should be advised from shoulder to fingertip, and the frequency should not be twice a day. It has to be many times, at least 2 to 5 minutes or 5 to 10 minutes, 6 hourly. And suggest them, don't do exercise for the sake of movement. You try to teach them the homebound activities like squeezing clothes or making a dough or a wax bath or wrapping the bed sheets or using a broom to clean the house, something like that. So we have to teach them homebound activities for the mobilization strategy. And after 2 weeks, if there is no relief at all, then we have to involve pain specialists to consider a stellate ganglion block or a sympathetic block. That definitely works in CRPS 1. Now, if you see this picture on the left hand, looks red, shiny, hot hand. It's a hyperalgesia, and this is the movement possible in the finger. And this lady had 4th and 5th metacarpal fracture, and she presented to us 6 weeks of post-trauma and excruciating pain on attempt of finger. And usually they are very sensitive to cold. So especially females in Indian scenario, if they can't work in water or water related activities, they cannot move, and then they go in depression. So such patient, with my medical management and the therapy under my supervision, the follow-up at 3 months, you see the complete color change. You can, from the movement, we can make out she must not be having any pain. And because now her right hand has started, or left hand has started working well, her psychological issues are also resolved. So now, take home message from my side is, we have to diagnose whether it is CRPS 1 or it is CRPS 2, and then we have to treat them accordingly. Referring them to therapists does not, I don't think so it is going to take away their pain, especially. And I support, I mean, I practice this based on these 3 literatures, the medical management which I have quoted. Thank you very much, Dr. Gautam sir, and all the panelists.
Thank you very much, Parag. I think a very nice lecture. The question is open to, the talk is open to the panelists. If you have any question, Parag, let me start. You mentioned in the very beginning that it is because of sensitization of cutaneous, but we have found even with spinal injuries, when the nerve is in the cervical spine and the compression is not relieved, they can present with the reflex sympathetic dystrophy of the hand. The other place where I have often seen, while working as a orthopedic surgeon in Rajawadi Hospital, is when residents tend to put in external fixators into the hand and wrist for lower end radius, and they don't dissect the tendon properly, and then it goes through the tendon, and patients land up post-operatively often with very severe pain. So my conclusion was that inadequate stability, and persistent inflammation, a low-grade infection, all these are features which lead to reflex sympathetic dystrophy.
Agree, sir.
Right?
Yes, sir.
Any other
Parag, I have a question. This is Dr. Swapnil Kenny.
Yes, sir.
Just wanted to know why is the incidence of reflex sympathetic dystrophy so low in children? In fact, it's unheard of. Any particular reason for that?
I don't know. I don't know how to answer this question, but yes, that is my observation too. Usually children, they move the part that has not been immobilized. They definitely move. In fact, if you in a supracondylar humerus fracture, above elbow cast also, when they leave the clinic, they start moving their hand so frequently. But that could be the only reason, and could be I don't know the answer of this question, but yes, I have also seen very less incidence of CRPS in children. Maybe one of the senior faculty, if they know, they can contribute. Dr. Thatte sir or Dr. Patankar, Dr. Bhatt.
CRPS option को डाला था.
One of the major mechanisms which explains CRPS is also cortical involvement and complete transformation in the cortical representation of these parts. And a lot of these are explained based on this, what Dr. Gautam said about spinal injury or any other areas also. So the mechanism is based on that, and even the interventions now are based on that. We start with mirror therapy, graded motor imaging, and so many other modalities come into picture only because of those things. So it's is a cortical kind of alteration which happens, and the patients perceive their hand or limb as a completely cut off from their normal body parts, and they don't even look at it sometimes. So that also explains the thing in children also, where the plasticity is much more, and of course the physical part, as Parag said, I mean, they would move even the injured part also nicely, so you don't need physiotherapy for them. But the plasticity in the brain also helps for children. I think that is the explanation I can think of, and the literature what we have seen. We follow the mirror therapy and graded motor imaging modalities in our setup regularly. And bisphosphonates is one other drug I can think of which has a level 1 evidence along with vitamin C for CRPS.
What about the role of steroids?
No role for steroids, no role for anti-epileptics, no role for antidepressants.
Right.
I agree with him, sir.
Whilst we are on this, Dr. Bhatt, I've seen that you have written papers on brachial plexus, so I'm going to pass this question to you. There is a question from one of the audiences that regional anesthesia, when it is given, occasionally patients land up with a neurological deficit post a regional deficit. You know, they have given a block or a regional block. So how common have you seen this? What is the management? Do they recover? What is the prognosis?
Well, I think it's a very important clinical documentation we have to make post surgery if the block is not recovering for whatever.
20 to 30% of the cost of the examen.
So
that should still be okay. You know, if you have about 200, then we have to go online. That's the only issue. Without
Dr. Hari, can you switch off your? Can you mute your mic?
Our level first, you know, so that we had to. That is some pedestal. Then at least we are looked upon. And
Dr. Hari, can you mute your mic, please?
So there are times where we have seen these long-acting blocks which don't recover even for 18 hours to 24 hours. So that is one part of it. Otherwise, if at all there was an injury during the procedure itself, I think immediately the patient has to be taken for an ultrasound examination and see if sometimes there have been injuries with the needle tip itself, where the foreign body is left behind there and there's an injury to the nerve itself. So there are various scenarios why injury can happen. And that documentation is very important. I think the basic treatment is wait and watch, and then go on for any further intervention only if there is no recovery after a reasonable period of time, which obviously is at least 2 to 3 months. I think Tate sir can tell more about that.
Dr. Tate?
No, I agree. Typically, it's a 26 or a 24 number needle, which a modern anesthesia department will use. So the quantum of nerve that needle can damage is not very large. Unless the infiltration itself happens intraneural, then the nerve will explode. But that's pretty rare. Really, really rare.
Yes, sir.
The real problem, Gautam, comes is people do shoulder arthroscopy under these blocks. And then they sometimes, this is what I have seen, they come with a musculocutaneous nerve injury. And the shoulder surgeon swears to me and says, sir, I am nowhere near that bloody musculocutaneous. So then was it the block, was it the musculocutaneous? I mean, the shoulder surgeon, there's no way of knowing.
No, it's difficult to understand that an injection would be given into the nerve like this, because even
I have seen it with my own eyes. I won't name the hospital. My own nephew was being operated for a shoulder. Ultrasound controlled block was being given. The nerve went through C7.
Achha.
I started injecting. I said, why are you injecting in C7? So he looks at me and says, do you know what C7 is? So I said, yeah, I see it every alternate day typically. So, they are pretty blasé about it.
Yeah. I think my experience is they try a lot in order to get the nerve. They usually don't get it. So if their anesthesia doesn't work most of the time. So anyway, with that, I'm going to take this opportunity before I ask Dr. Hari Venkatramani to give some concluding remarks on the session today, I'm going to take this opportunity to thank firstly Dr. Parag Lad, who has put efforts to put this program together and really coordinated a beautiful show. I would like to thank all the faculty, right from Dr. Mukund Datte, who was my teacher, to Dr. Anil Bhatia, Dr. Amit Vyas, Dr. Anil Bhatt, Dr. Hari Venkatramani, Dr. Bipin, Amit, and Rohan,
Leena madam.
Lena, all the people. Sorry if I'm forgetting any names, but each one of you have made a beautiful presentation. I'm sure the audience has loved it. And I'm getting so many messages already that it's been a fantastic program. So thank you very much. I would also like to thank the Bombay Orthopedic Society audiovisual team, the technical team consisting of Dr. Kshitij Chaudhary, Dr. Mahesh Karde, and Dr. Swapnil, our secretary, who have put in enormous efforts to make sure this program goes very well. And with that, Parag, a couple of words from you, and then I would like to request Hari to give a brief overview of what we have discussed today.
Thank you, Dr. Gautam sir. Being a practicing hand surgeon, even this session was very, very useful to me. And I am really thankful that many of the Indian Hand Society colleagues also watched this program. And it must be definitely a good academic feast on this Sunday. And of course, Dr. Hari will definitely conclude on every topic. And first time we could, last moment, yesterday evening, we got the message that this course has been accredited, even for at least 1 point. So that also was the another feather in the cap. And I thank all my seniors and teachers and colleagues to participate in this session. Thank you, everyone. Over to Dr. Hari.
Thank you, Parag. I just like to put a slide because I was asked to present, so I thought better put a slide. Easier to present with a slide. Yes. So when sir asked me to give a conclusion, I thought it was, I think all speakers spoke very well and the points were very good. So I like to put this slide because this was Dr. Antia who first said how to become God of plastic surgery. So I put it as a God of nerve surgery. So if you want to become God, which is G for God, actually G should have been capital. G for God, you need to be from A to F, and A is for anatomy. I think the one take-home message from all the presentation is that you need to know your anatomy very well. Anatomy is like an internal GPS. If you know the anatomy, I don't need to tell people of Bombay, you know the road so well. Many times you don't have to follow the GPS because you know the roads. So if you know the anatomy, you can practically go in and out of any area of the body, and especially upper and lower limbs. So A for anatomy, B is books. There are so many online material available now. And my suggestion to all young budding surgeons is that before you embark on any surgery or any new surgery or anything you have not done in the last 3 months, please refer to the book. And please, if you don't know which book, then you can always consult any of us and we will suggest you what to read. Third is to develop a lot of common sense. Most of us are not born with common sense, so we need to develop common sense. And common sense means if it's telling you that, like what we saw, a K-wire is fixing, or if K-wire cannot go in that region, as Dr. Anil Bhatt said, it is from the lateral approach. That means you have corrected the deformity. So common sense tells you there is a stretch of the nerve. And most time, common sense is always right. So follow your common sense and go for it, and then use. Once you find out what is the problem, then you use your knowledge on the diagnostics. The fourth, that the D for diagnosis. Every patient you see, you should sort of pinpoint the diagnosis. It can also be, I don't know the diagnosis. That could also be one option. But you try to pinpoint the diagnosis. Where is the lesion? What is the cause? What is missing? And what is present? So you need to have your diagnosis correct. And E is for education. So all this program which you say, all of you, if you learn 10 points from today's lecture or today's program, you go and educate 10 more people. The more you educate, more you tell, the more you'll remember. It's always said that old people, especially grandparents, remember the stories if only they have grandchildren to tell them. If you don't have somebody to tell your story, you will forget your stories. So please educate people around you, your nurses, paramedical staff, your fellows, and all your physiotherapy and support staff. And F is very important, follow-up. Every patient you operate, you see. Even the first lecture by Dr. Anil Bhatia was so good that he put a Saturday night fever and Saturday night palsy. And then he showed the follow-up, so meticulous follow-up, which showed recovery at repeated periods of time. So if you don't have follow-up, most of the time we don't learn anything. Any learning, as Michael Gladwell says, that learning is always when you have follow-up. And one area they found that which is got maximum amount of sort of learning is pathology, because they always have follow-up. But whereas radiologists have got very less sort of education because they don't have a follow-up. Most of the time they don't go back and inquire what happened. So if you have follow-up of all your patients, you will get extremely good outcomes. And finally, if you do that, you become God. And most important, I added H to that, be humble after you become God. I think that sums up everything. So if you need to take home message, anatomy, books, common sense, diagnosis, education, and follow. Thank you very much. And over to Parag.
And thank you, everybody. We now leave you, and we would request you to join us on November 1 for our next Masterclass program, which is a pediatric program on angular deformities in children. So please do join us. Thank you very much.
Reduce the time, your time. And
Thank you. Thank you.
I interrupt here, Dinesh, on this point.
Thank you.
I don't know about others.
Thank you.
But actually, the work has not been allotted.
Yes, even I have.
Kshitij, can we end the meeting?
More or less been pretty prompt in doing it, but
You can stop the live stream.
Audible.
I'm ending
I agree about getting more articles and all that, but in terms of editing, we could take some burden off your shoulders. But if we just distribute it, if you just so, get happy to change.